Welcome back to HIMSS Day 3. Right here, HIMSS 18. I'm Adam Johnson, your host on HIMSS TV. We're so excited you're with us. I know that there are a lot of you who couldn't be here, but it's okay because we're bringing you here. You and 45,000 people who are live here in attendance. We heard so much on day 1 and 2. On day 3, today we're going to bring you so much more, so many wonderful interviews. And I think if there's a takeaway for me, it's the sense of partnership, cooperation here at HIMSS. We can talk about artificial intelligence, robotics, biometrics, value medicine, telemedicine. I mean, there's so many different themes, but if there were an overarching one for me, it's partnership. And you're certainly our partners watching. And so we want to get right to our first guests. And you know, we talk about innovation here at HIMSS. Certainly that's part of the story. And innovation is about teamwork. It's also about having a plan. And I would argue that our next two guests have both. They are Susan Dentzer, President and CEO of the Network for Excellence in Health Innovation, and Sara Vaezi. She's Chief Digital Strategy Officer, Providence St. Joseph Health. And we're joined now by Susan Dentzer, President and CEO of the Network for Excellence in Health Innovation, and Sara Vaezi, Chief Digital Strategy Officer at Providence St. Joseph Health. Thank you both for being here.
Great to be with you, Adam.
You are partners in an exciting program called Healthcare Without Walls. Susan, why don't you sort of give us the overview?
Great. Well, thanks, Adam. Well, at NEHI, Network for Excellence in Health Innovation, we're all about working with our members across 90 different organizations across all the key sectors of healthcare to advance innovation that improves health, improves the quality of healthcare, and lowers the cost. And as we started to look about ways to innovate, we said, look at all the technology that we have around us today. We have telehealth. We have all kinds of digital health. If you look at the categories of healthcare that are about exchanging information, not about the laying on of hands, why hasn't all of that moved to a more virtual setting, the way almost everything else in our lives that's about information exchange has moved to virtual settings?
Healthcare without walls. Get rid of the walls.
Why not get rid of the walls to the degree we can? Now, we're always going to need some walls. If you're in an accident, you're going to want to go to a trauma center. That's a given. But there's so much else going on in healthcare that really is about exchanging information, whether it's giving yourself a lab test and giving the results into a computer that can be analyzed by your doc, having a telehealth visit. All of those things really could happen virtually and really have the magic of bringing healthcare closer to where people are in their homes, their offices, their communities. So our project is all about looking at how do we make this more distributed form of healthcare more common, more universal throughout the country, and what obstacles do we have to remove to get there? And because it's healthcare, there are innumerable obstacles standing in the way of really seizing this potential.
Well, and that's where you need Sara to actually come in with technology, right? I mean, that's in many ways it's the great equalizer, but it's also the lever that opens things up. So what's your role in this grand experiment?
So as it relates to what we're doing with NEHI, Susan has compiled 5 different work streams. There is a human factors work stream, there is payment, regulatory, workforce, and then finally, last but not least, there's technology, which is really the sort of the grand enabler for all of this.
Yeah.
And as part of this work stream, we are really looking at what are the sort of digital health tools, what are the insights and data components, what are the tech-enabled services, what's the underlying infrastructure, and how do they all work together to achieve this distributed network of care. And what that ultimately means from a patient or consumer standpoint is bringing care to where they are on their terms, as opposed to how we've sort of traditionally done it, which is on our terms and what works for us.
Yeah, you know, that's one of the themes I've noticed over the course of the past several days. It used to be that the doctor was on high and the patient was somewhere down here, and there seems to be this kind of meeting somewhere in a gray area. I guess that's something to embrace.
It truly is, because for one thing, we know that self-care of individuals is so important and really needs to be held up and reinforced. I mean, we spend most of our times outside the healthcare delivery system. We think it should be even more time outside the system, but connected to a system and connected to people who can support you in maintaining your health, preserving your health, and dealing with any conditions that you may have.
You mentioned sort of a great equalizer.
Yeah.
The internet is a great equalizer, and one of the things that our group at Providence has done that we're trying to bring within this Healthcare Without Walls initiative is the internet is out there, our customers are out there, they're online, they're looking for us. There are 30 million Google searches every single day that are healthcare related. How do we...
30 million a day.
30 million a day. It's actually the most common category of search within Google, and Google owns the internet. So
They do.
So
Facebook wishes they didn't, but they do.
they do. And so how do we position ourselves to be out there? Providence is building a transactional platform where we can actually do that. So we are meeting our customers where they are, and then using that transactional experience to then create a better experience,
Sure.
and then translate that into ongoing engagement.
Help me understand when you say transactional. To me, that almost sounds antiseptic, or like I'm going to an ATM machine and I want my doctor relationship not to be so transactional, but to be human. So
Yeah.
how do you humanize or balance that with transactional?
Well, first, what you need to do is actually make the experience better and less friction, with less friction, and that's part of making it, enabling that human interaction too. Right now, it's so bogged down with just inconvenience and all sorts of other things that make it so unpleasant for the customer that the transactional experience, frankly, sucks. And so we need to overcome that before we can really get to the human aspect of it a little bit. So when we talk about transactions, we mean, for instance, scheduling that is convenient for you. It's done online where you already are.
Sure.
It's payment in a way that makes sense. It's not confusing. You know what you're on the hook for. You know in advance what you're on the hook for, and then it's tied into your insurance. So that's another way. So there's this full frictionless experience that makes that transaction better, and then you can really take advantage of the relationship with your provider once all that other stuff becomes transparent and sort of melts into the background. But that's only a small part of it too. There's all sorts of other technologies that we're considering that also feed into this. I talk a lot about what we're at Providence doing, which is based on this transaction and then the ongoing engagement. But there's a lot more there.
Susan, I understand. You walk into an office, you say, we're going to knock down the walls, and people say, great, tell me more. And then you actually have to do it. So where do you start?
Well, I think first of all, you start with leadership, a commitment of an organization to say, we're going to change. We're not going to do things the way we used to do. If we really think there's value in hauling patients into a waiting room and have them sit for a couple of hours before an appointment, that's one thing, maybe not so much, right? So a commitment to change. And all around us, we see organizations changing in various ways. Providence St. Joseph, as you've heard. Mount Sinai system in New York, moving to hospital at home. Are there patients who are sick but not too sick, who actually could be hospitalized at home, in effect, have the system go to them in the form of doctors, nurses, and others visiting, have telehealth consultations as needed? Hospital at home is a model that has been shown to have amazing patient satisfaction, and it cuts the cost of inpatient care by about 20%.
By about 20?
About 20% overall in all the experiments where it's been tested. So, but that didn't happen because Mount Sinai sat there and said, how can we fill up our hospital beds? They said, we're going to have a different health system, and we're going to try these new approaches. So it starts with the leadership. It starts with people recognizing that, frankly, people do spend most of their time, even if they're sick, they're spending most of their time in homes and communities. And also recognizing that the upstream drivers of health, the social determinants of health, the things that are really predisposing you in life to health or sickness happen way outside of the healthcare setting. And you can't really connect to those as a healthcare provider unless you see it in action, unless you understand that somebody's living in inadequate housing or roach-infested housing, or doesn't have access to healthy food. You got to get out from the walls and into the community to understand that. And we think systems around the country that are making that commitment are going to have enormous results as they put all these pieces together. The desire to be moving outside the system, the technology that enables that to happen, and really delivering on the promise of meeting people where they are to support and advance their health.
So if people want to know more, where can they go within the hall? How can they hear you at a breakout session over the next couple of days?
We have one more session coming up tomorrow. It's look on the HIMSS app for MIHI and Healthcare Without Walls. That will pop right up. You can also access our special dedicated website for the initiative, healthcarewithoutwalls.net, or come directly to our NIHI website at nihi.net for more information. We want very much to engage people and systems that want to move in this direction. And the next phase of our project, after we come out with recommendations later this year, is going to be precisely that, engaging with people who want to test out new models of delivery, of payment, etc., to really make this a reality. So we hope to make as many connections as we can.
Love it. Well, thank you for both being here. It's a wonderful story, Healthcare Without Walls.
Thanks
Thank
so
you.
much. Thank you.
All right, it's time to hear from one of HIMSS' own, Rod Pachowski. He's our Senior Director of Health Information Systems right here at HIMSS. Rod, you've just presented a new survey on cybersecurity, and I imagine that session was very well attended. Tell me about it.
It was. In the Cybersecurity Command Center here, which is twice as big this year as last year.
Tells you something?
We're in 2 ballrooms. We have 2 theaters, 1 in each ballroom, and this morning we kicked off with a little story about the cybersecurity survey. It was packed, standing room only. I think it's a corner of the room, and we had overflow crowds, so there were probably 60 or 70 people in this little corner theater, so it was very nice.
So you conducted the survey leading up to HIMSS so that you'd be able to present it. What are some of the conclusions that came out of that cybersecurity survey?
Sure. So one of the really interesting points, I think, is that we had 239 respondents, valid responses that we could use, and 75% of the respondents said that they had had a significant security incident in the past 12 months. And I think another 21% said they did not. And so you take it with a grain of salt, but I think it's very impressive that 75% of the respondents admit to having had that, and that changes,
that they admit to it.
Right, and that's so different than 3-4 years ago, even when people kept this to themselves and they never shared that they had had these types of incidents. So it's very common, and it's tough. It's a hard job to secure all of this.
A lot of the cybersecurity attacks go unnoticed. Why do they go on so long before people realize, wait a minute, we've been violated?
That's a really good question. Not everything manifests itself as a breach or an exfiltration of data, if you will, immediately. It's quiet. You don't hear electrons moving through your systems, right? You don't hear data moving around. So there's nothing to really alert you unless you have systems that are designed to watch for unusual activity. And one of the questions that we asked people was, how long did it take you to identify the fact that you had had a breach? And some people knew that day, other people responded that it took a week, or in some cases it takes 6 months. And some organizations find out using their own staff and technology, and others have third-party help, managed security services, for example, or a law enforcement agency might inform you that your organization has been revealed to have had a breach in this other investigation.
Given that so many, I think you said, what, 75% of the respondents had been breached, what are the emerging best practices in dealing with the breach once it's happened?
Well, the best thing that an organization can do is be prepared. The more mature organizations have playbooks, if you will. They know in the event of this, grab book
It's already been drafted.
It's already been drafted. They know, turn to page 5, do this, then do that, then do this. And it all depends on the type of incident and how you are going to handle it.
How effective are we at creating structures, walls, that are truly secure and that will stop breaches from happening?
I think we're getting better. Way better, and a lot of that has to do with awareness on the part of people who work at these organizations. I think traditionally, people who work in healthcare assumed that security was a part of information technology. It was their responsibility. Security was something they did. And what we're learning is that everyone who works in an organization, if you touch data in any way, if you interact with patients, if you collect data, if you touch a computer, you are responsible for the security to some degree of that information. And by extension, you're responsible for protecting the privacy of the patient, as well as the safety of that person while they're under your care. So that has been a real change, and we've started to see more and more organizations do more broad training, and the awareness factor has gone way up, and we think that's a really good sign.
That we're all involved, we all have a hand, and therefore we're all responsible.
Exactly.
All right,
it's
Ron,
true.
Thank you.
You're very welcome. It's my pleasure.
Good speaking with you.
All right, thank you.
If you've ever had an MRI, chances are pretty good it was in a machine made by GE. Everyone thinks about GE Healthcare as this massive organization that produces all these incredible devices that have saved so many lives, and it's true. But you may not have realized that GE is also a very powerful investor in venture capital. And I actually had a chance to sit down with the woman who runs it all. Lisa Suenin is her name. She's the Senior Managing Director for Healthcare Ventures at GE. Great conversation. Lisa, you run one of the largest venture capital firms in the world, in effect, right?
Well, I run the healthcare part of it, certainly.
The healthcare for GE, I mean, that is more than significant. So it's an honor to be able to speak with you and get inside your process.
Pleasure to be here.
What do you look for as you're trying to allocate literally billions of dollars of capital in the healthcare space?
Well, we don't allocate billions on the venture side. We certainly do as a company. On the venture side, we make probably 5 new investments a year and invest, under $100 million in new capital every year. But we are really excited about anything that advances precision health in the broadest sense of the word. So when I think about that, I think about anything that helps support patients all the way from the social determinants of health and solving those types of challenges through the delivery system on the clinical side, all the way up through precision medicine. So we invest pretty broadly in those various areas.
What does it take to get? What does it take for a company to get your team's attention?
We're looking for companies that have proven some product market fit. Generally, it depends on which side of the business we're looking at. So on the health IT and IT-enabled services side, we're looking for companies that have some revenue, that have, demonstrated they do what they say they do, that they can save companies money, as well as improve clinical outcomes or operations. On the more life sciences side, we're looking for companies that make tools and services that advance the ability of pharmaceutical companies to bring drugs to market faster. So we do a whole broad thing there, everything from discovery to genomics related things.
And only 5 a year get the nod.
Yeah, we see probably 1,500 a year.
Incredible. How many people are working within your group to try to narrow that list down?
We have 6 in our group.
6 people? Mm-hmm. Do you ever sleep?
Sometimes.
I mean, it's incredible. It must be like trying to take a sip of water from a fire hose. There's so much coming
Yeah,
at
but it's
you.
so exciting. All day long I get to listen to the people come up with great ideas and tell us why they're going to change the world. And, of course, they're not all going to do it, but at least, the excitement and the creativity is really infectious.
What are a couple of the projects you can't tell me who they are, what they are, but just conceptually, what are some of the projects you're looking at right now that you're thinking you may actually make as 2018 investment candidates?
Well, we're looking at a number of companies that address the data amalgamation problem and how to use, but do something actionable with that.
Yeah, right.
I think there's a lot of companies using, AI or call it what you will.
They throw it around, but now what are you going to do?
But now, what problem are you really solving with that? So things that are solving real problems.
And what kinds of problems do you want to solve?
Better drug discovery, identification of clinical risk before people have horrible conditions, befall them. Identifying needs for equipment before it's needed, so you're sort of prepared in the operating room or in some other part of the delivery system.
So that's the AI side of it, where you're crunching big data in order to try to then apply the little data, the individual patient, where that person fits in.
For sure.
And it's largely, it sounds like, preventative.
We deal on both sides, prevention and treatment. We don't do a whole lot of stuff in primary prevention, more in the prevention of returns of chronic conditions, things of that nature. We have a company, for instance, called Health Reveal in our portfolio that uses AI and machine learning and all that, buzzwordy stuff to, use data from across the spectrum of patients to identify at a patient level, are they likely to have a really negative material adverse event from a condition they may already have. So for instance, somebody with AFib who might be at risk for a stroke but really doesn't know it, isn't being treated properly,
right.
You can use the data you find about them to say, this is a person who's very likely to have a serious adverse event. Let's go take care of them before that happens.
All right, how many people have pitched you on investing in their companies while you've been here?
Only a few, because I've only been here a couple hours, but
You're not wearing your GE pen. That was smart. That's called survival.
It's easy to get buried.
Lisa, thank you.
Thank you so much.
All right. HIMSS is proud to partner with innovative companies like Optum, and earlier I had the chance to meet one of the men behind the innovation that happens at Optum. He is Dr. Darshak Sanghavi, Chief Medical Officer for Optum Labs. How do you approach now in your role as Chief Medical Officer at Optum what you want to go after? How do you prioritize the different diseases and issues?
Yes, it's a great question. We try to go after the things that have the most impact. And so it might be the problems that affect the most number of people, the problems that are most expensive, or the problems that result in the most misery in some ways. So we really try to shoot for those targets, we swing for the fences, and that environment that we're at allows that kind of innovation. Sometimes we succeed, sometimes we don't, but at least we're trying to go after the stuff that matters.
Yeah, right. What are the top priorities for 2018?
So we have spent a lot of time on the opioid crisis. It's now the leading cause of death in young people. It came on so suddenly. We think that that means that perhaps we have reason to be optimistic that whatever it was that made it come on, perhaps we can reverse engineer that and actually lead to some improvements.
How do you go about doing that?
So it's almost the same as how do we treat a complicated problem like cancer. The first thing you do is a diagnostic scan. You do an MRI, CAT scan, you find the tumor, and then you test it. You say, well, what are the treatments that are going to affect it? Then you go back and scan again. It's the same with the opioid crisis. We created a framework. So we looked at, are we prescribing too much? Are we actually then helping people avoid chronic use? If they become dependent on opioids, are we helping them the same way? And then we intervene, we change benefit design, we make sure they have access to the right medicines, and then we run the analytics again. We repeat that cycle over and over, and hopefully at the end of that, we've helped our members feel better.
And what's the message of big data with regards to little data? Collecting data on lots of people who suffer from opioid crisis and then dealing with the one.
Well, I think the issue is that when you just have one person in front of you, you're not exactly sure what's going to happen to them.
Right.
If they're on a certain dose of medication, if they actually have a certain type of exposure, they live in a certain environment, they have a certain kind of insurance, you just don't know because you have a small sample size. Big data, all it does, it gives us statistics. Just like, if you're going to flip a coin, if you flip it 100 times, about half time of your heads, half time of your tails, it's exactly the same way. We want to look at those patterns and then use that intelligence to come back and help that person make the right decision.
As much as we know about the opioid crisis, why would any doctor today prescribe an opioid?
Well, opioids are effective for pain, and used correctly, they are terrific in many ways. However, the issue is that they're not always used correctly. And part of the problem is that physicians and others have developed habits, some on their own and some that have been imposed on them, potentially by pharmaceutical marketing practices and other strategies that have led them to learn the wrong ways to prescribe and take care of these patients. Patients also, to some extent, are expecting a medicine that might work immediately without thinking about the long-term effects. So I think we're trying to assume positive intent. Doctors trying to do the right thing, patients want to do the right thing. Our information, the research we're doing, hopefully will help them make those better decisions.
So obviously the opioid crisis, one of the pillars that you're trying to knock down. What's another?
So another key area we've been working on is Alzheimer's disease. Again, affects lots and lots of people, tremendous human cost, and research is still in its infancy, to be honest, to help us understand how to both prevent Alzheimer's disease and then treat it as it moves on as well.
And how does Optum IQ as a platform enable you to do that?
Yeah, so Optum IQ at its most basic form is exactly what we talked about. It's taking the data, putting it in a form that makes sense, analyzing it, and then using insights to drive better health in some way. So with Alzheimer's disease, that's exactly how we start. We have lots and lots of data, tens of millions of medical records. We try to create healthcare intelligence. So we've created an artificial intelligence model. We're using a deep learning model to see if we can predict who's going to develop Alzheimer's disease. And then we take that information and then we work with our partners, perhaps pharmaceutical companies, so they can identify people that are at higher risk, or maybe our care managers so they can reach out to these patients, help them actually prepare for these problems they may develop over time. So it's that sort of three-part structure, and we hope that in Alzheimer's disease, opioids, and in potentially dozens of other areas, that same strategy can be effective.
So obviously the key to data is data collection, which means patients have to participate. They have to be willing. How are we nationally on the mindset of getting people to take responsibility and actually collect data or do stuff that collects data for them?
I think we're at a point where almost all patients realize that having their information available both to themselves and to their physicians and potentially other researchers to help others, that is a sale that's been made, so to speak.
So we're there.
Most people
That's the
feel
good
that
news.
way. Yeah. I think people want to donate their data. They want to have access to it. They want to own it. That's not the hard part. The hard part now is actually creating the technology that actually makes that a reality.
And where are we on that scale?
Yeah. So we're still making progress there. I think that
means we're early.
Yeah, we are early. You know, I think anybody who's tried to get their medical records from the hospital could probably understand that we've still got a little
Just trying
ways
to get
go.
X-rays impossible.
Yeah. But I think it's better now than it was 2 years ago. And I think that 2 years from now it's going to be better than it is now. So part of it is, can we accelerate that transition? I'm optimistic.
Do we need a sort of nationalized standard or code to facilitate that? Or is that sort of happening almost like blockchain in the background? It just kind of happens.
That's a good question. I mean, I think that just as the internet really exploded when there was a standard to some extent, so everybody knew that there were some basic things that had been agreed upon. I think healthcare information is very similar in that way. Those standards exist. The extent to which that they need to be expanded still remains to be told.
Yeah, it certainly does. We could go on and on and on. Doctor, thank you for being with us today on
It's a
HIMSS
pleasure
TV.
to talk to you. Thank you.
Likewise.
Listen up, heart disease. You too, unnecessary ER visits. And hey, unmanaged depression. Don't get too comfortable. We're talking to you, cost inefficiencies and data without insights. And fragmented care. Stop getting in the way of patient recovery. And pay attention. Every single one of you is on our list. At Optum, we're partnering across the health system to tackle its biggest challenges. Optum, how well gets done.
Innovation is everywhere, certainly everywhere at HIMSS, and it's everywhere in healthcare. I mean, you think about it. It's not just medicine, it's IT, it's data, it's robotics, it's medical devices, it's also hardware, the computers we use in operating rooms and emergency rooms. And who better to talk about that than our next two guests? They're with Lenovo, computer makers. Bobby Juergens, he's Director of Healthcare Sales East with Lenovo Health, and Wyatt Yelverton, Health Solutions Executive, also with Lenovo Health.
So as a hardware solutions technology company, we see a couple of areas where we can partner with the providers and address a few challenges. Number one is we shift from this volume-based to value-based care system. Solutions like telehealth, telemedicine, remote patient monitoring are becoming much more prevalent and much more necessary to have discussions around. Number two, how can technology help improve patient experience, promote that patient engagement, and really that patient engagement all the way through post-discharge into a virtual care setting. And then number three, these care providers, they need constant, always-on access to that patient data. How can that technology help deliver that? And obviously that patient data has always got to be protected and has always got to be secured. First and foremost, mobility, clinical mobility is king right now. As opposed to the old school of bringing the patients into the care, now it's about bringing the care to the patients wherever they may be. So these clinicians need devices that are rugged, secure, mobile, and flexible, whether it's the device that they're using inside the brick and mortar walls or whether that's the device that's going out into the patient homes or into the nursing homes. So we've got to be mobile, we've got to be flexible, and we've got to be secure.
The accessibility to patient data is becoming a pivotal ability for providers, for ancillary care staff to really care for patients and to deliver care in a personalized way that's relevant for that particular patient's needs. Ultimately, what we're looking for in technology is the ability to freely move data across the care continuum, whether it be from a clinic to a hospital atmosphere or from that facility out to a patient's home. It's pivotal to be able to make insights that are relevant to a patient in a continuing and ongoing way, such that as the patient's needs evolve, we are going to be there not only to be able to react to a patient's expectations, but to anticipate them and provide what it is that they anticipate of us as professionals. Innovation's really designing the future of how it is that we're able to deliver care to our patients. When we think about sensor technologies that are able to make clinical grade diagnostics outside of a medical facility, or new emerging technologies like AI and AR that not only allow us to interpret a patient's health and well-being on a completely different scale, but allow us to make decisions about delivering care to our patients wherever they happen to be. Our goal ultimately is to be able to facilitate that transfer of care, not just necessarily from a facility to a patient's home, but to make the care process ubiquitous wherever the patient happens to be.
Well, Lenovo's legacy was built on innovation. Our relentless pursuit of innovation. We've got to be quick, we've got to be nimble, and we really have to stay ahead of this market. We're also committed to making sure that our customers thrive in this value-based market that we're shifting towards. And number three, we want to ensure that your experience, your clinician's experience, and your patient's experience is one to be modeled in the market.
Economics is the language of how people and businesses come together. It's also a passion for our next guest, Jane Sarasin-Khan. She is a lifelong lover of economics, and she is a health economist. It's why she founded a company called Think Health. Jane, a healthcare economist.
Yeah.
I love that. It's so specific. Tell me about your day.
The day today?
Yes.
The day today has been manic. They call it HIMSS Sanity for a reason. This is my 20-something HIMSS.
Impressive.
So my whole career I've been a health economist since leaving graduate school in the late 80s. And that means I think about healthcare, health policy, the people who consume healthcare, and most importantly, the consumer, the patient at the end of the day. So today was thinking about that patient, the consumer in the healthcare system, and how technology can help improve the patient experience, help people self-care at home, stay the heck out of the hospital and the doctor's office. For me, that's how we bend the cost curve, which you hear about politicians talking about all the time.
Of course.
But they need to understand how health apps, mobile telephones, and broadband and bandwidth and net neutrality is important for the health of the people.
Would these conversations have happened 5 years ago?
They were happening with some of us wonks who were forecasters like me. I think about the future of healthcare, the $3.2 trillion we spend on healthcare. Keeps me up at night. I'm an economist married to a banker, so our household is very quantitative. Exactly. And my husband's an international banker, so I mean we have heavy talks at the dinner table about the world and people and how we're going to live and sustain the future. And so 5 years ago, some of us were thinking about this. 5 years ago was the early days of the patient being discussed here. At that point, I was part of the HIMSS Connected Patient Committee, and we helped bring the mission of patients to HIMSS. So that was about 5-6 years ago.
And what's interesting, the connected patient 5 years ago was probably a patient laying in a bed with a bunch of wires attached to him or her, whereas now
Yeah.
the connected patient is someone walking around with this.
Yeah, or this,
Right.
or stuff I have under here that nobody knows that I have on.
Or woven into your shirt,
Yes,
or on and
exactly.
on. Yeah.
Very smart.
Right.
Now it's in your car. The connected car increasingly will sense your high blood pressure through the steering wheel, will sense the dirty air outside, roll up the windows and turn on the air conditioning if your app knows you have COPD or asthma.
So it's really technology that is enabling us to attack this high cost basis that is making healthcare unattainable for so many.
It can be. That's the Holy Grail vision.
Right.
As long as we note some of the barriers. I mentioned bandwidth earlier.
Right.
One of the big barriers to a lot of people engaging with this kind of technology is privacy. We only have HIPAA, which deals with data in the medical claim, in the doctor's office, in the lab, in the hospital. But this stuff that comes out of our wearables, the stuff on your phone,
Sure.
may relate to health, but it's not covered by HIPAA. And a lot of people don't realize that. And so one day when somebody gets cyber hacked through an implantable cardiac defibrillator,
Right.
or like Dick Cheney wore when,
Yeah,
when,
sure,
he,
right.
when he was around in politics, or any other kind of hack that people have, like an Equifax type hack, but it
Yeah.
has to do with your health data, you take that really personally, and that could really have a backlash against all of this stuff. So we really want to try to tighten up the data, bring bandwidth to everybody, not just wealthy people who can afford a good data plan,
Right.
So we can democratize this access to all this great stuff that
Yes.
we see on the show floor.
Yeah. What do you think that that hacking, cybersecurity, the breaches, all that, what do you think that costs us every year?
It costs a lot of money. The reason why hacking of a medical record has gotten very popular in the last couple of years is the medical record data is worth a lot more than your general bank data, because they not only get your social security number often, but they get lots of other personal data about you. So I just wrote about this for a book I'm writing, and the cost or value on the street of a medical record is like 3 times the amount that your just banking record is.
But here's the thing, if I steal someone's credit card information, I can use that to go spend money right away. What am I going to necessarily do with the health information?
Identity theft, passport, all kinds of untoward things. But the identity theft is a big deal.
Right.
You can even now, I've heard, figure out where someone's mortgage is and deleverage their house and get the value out of it by assuming an identity that way. So it's worth an awful lot. The bigger cost, besides dollars, is trust in the health system.
Yes.
And then it forces people not to engage, not to provide data, sensitive data like HIV status, mental health status, things we really want to know about the whole person so we can take care of the whole person. And particularly the mental health data, which we know
Right.
is so important to bundle in with all other health care too.
All right, so again, speaking as an economist, what you have to do really is weigh the fact that we have this new technological capability through the Internet of Things, and yet somehow if we don't make it secure, it's all for naught.
That's right, and we're finding that now if we think about the Internet of Things at home, healthcare aside, a lot of people will not buy these Internet of Things things.
I don't want an Alexa in my home for that reason.
Yeah,
It's
see,
an intruder.
A lot of people are buying Alexa without realizing Alexa is really always on. Alexa hears all, not just when you say, Alexa, wake up. Alexa's got to hear you to say, Alexa, wake up. So what does Amazon know about us? They know everything I do about books, and I'm even buying laundry detergent on there now. But there are many things I don't buy from Amazon anymore. As much as I love Prime, and I'm primed for instant gratification for my health, I'm going to be a late adopter of that.
Well, we are certainly primed and happy to hear you at HIMSS. Thank you, Jane.
Thank you so much, Adam.
All right. Public-private partnership. You hear a lot about it. You certainly read a lot about it. The question is, does it work? Well, it depends who you talk to, and our next two guests say yes, absolutely. It not only works, it's also the future, in part, for success in healthcare. Esteban Gerchak, MD, Chief Information Officer for the state of Louisiana, their Department of Health, and Jim Geringer, former governor of Wyoming and the Director of Policy and Public Sector Strategies at the Environmental Systems Research Institute. These are two gentlemen who are very adamantly in favor of public-private partnership. Dr. Esteban Gerchak is Chief Information Officer for the Louisiana Department of Health and Government. And Jim Geringer is the former governor of Wyoming, Director of Policy and Public Sector Strategies at the Environmental Systems Research Institute. Gentlemen, what a pleasure having you here.
Well, thank you for having us.
And you, the two of you have actually, from Louisiana and Wyoming, across state borders, and you've actually worked together for a number of years on bringing people together. Tell me about that, if you will, Governor.
Well, we have. The State Advisory Roundtable under HIMSS is an affiliation of many state officials elected and appointed for a variety of reasons, or career people that work in the arena of public health, specialty health, health policy, advising HIMSS on how they can approach the states and understanding the state's particular challenges in dealing with healthcare issues, and then how that translates into the use of technology in a very useful and efficient way, very effective way.
And doctor, is it easier for states to do this than for the federal government?
I think from each state we've learned different lessons learned. So different states have different barriers to interoperability, data, partnerships, and so forth. So we've been able to learn from one another how we can partner, how we can have lessons learned so that we can address such issues as disaster management, opioids, and other things that affect our different states and public health.
You know, just this morning I was reading in the Wall Street Journal that something like from September of 2016 to September of 2017, the number of opioid cases increased 30%. I mean, it's mind-boggling to me that that doctors are still even prescribing opioids, and it's getting worse, not better. Where's the disconnect? That's a toughie to address.
Well, it is. You know, if you look at the traditional ways of approaching any kind of an issue, and this turned it from a behavioral and medical issue into a epidemic. So what you usually do with a major epidemic or an outbreak, say the Zika virus or a flu epidemic, is you start to look at the precursors that will give you an indication of something happening. So that as you look at like a flu epidemic, you look for over-the-counter sales, and then you look at what's happening at clinics, and you look at what's happening with hospitalizations, and if there's deaths, you coordinate the entire spectrum of care in a community for behavioral health, for economic factors, social, not just the physical environment. You look at ways to bring all that information together so you can do some prediction about where something is going. On the flu and Zika virus, those things were assembled into an action plan. With opioids, people didn't connect all those bits of information to the point where they could have intervened at an earlier point and said why and where could we intervene. And I guess we thought we had kind of started to bend the curve down as states, and then all of a sudden it's starting to increase again.
Yeah, right. You know, it's interesting. I understand you're a chief executive, but you sound like a data scientist.
Well, I do a lot with data.
Yeah, clearly. I mean, you speak very eloquently and passionately about it. How's data driving what you're doing in Louisiana?
Well, I think we found that it's important, as we've learned in other states as well, that we need data-driven solutions to what we're doing across the state, whether it's from a flu or Zika epidemic to the opioid epidemic to disaster management when we have hurricanes hitting our shores. So it's one of those things that the same themes sort of align around all of this as to what's the data, where is it, who owns it, how do we clean it, make it accurate, how do we link different data sources around the community.
And that's a very specific process, what the two of you are outlining. I mean, this is something that applies to almost any type of healthcare or any critical issue, isn't it?
Critical issues, especially a crisis response, but what you try to do is you back up and say prevention.
Right.
The first element in any kind of community health is prevention, early intervention. Then you start to, you know, as things parse out and you have to do something, what do you do? But Esteban mentioned something very crucial to that, and that's authoritative or reliable data. How do you assure that the quality of data is there? You look at an entire spectrum like community health, but you also look at individuals. You want to have both of those happening, and for preparedness for something like he's described, how does a community work together on a routine basis? If they establish those protocols, the data exchange, the reliability, the exchanges, the interoperability, then it will work in a crisis. If they haven't done it on a routine basis, it doesn't work in a crisis.
Sure. How does Louisiana deal with that?
Well, I think what we've learned, and as we've learned from other states, I think the state advisory panel has sort of helped serve to build partnerships. So I think from a state entity, you're the one convening the partnerships around all the different components in the state, whether it's from a medical standpoint, from a social services standpoint. Again, with the opioid epidemic, it's something that crosses through state troopers, crime lab, coroner offices, behavioral health. It sort of gets the full spectrum. So as a state entity, you're able to build those partnerships and align those people at the table and work together both in the public and private sector together. So not just to have the correct collect data and to link it, but then down the line to do that predictive modeling so they can be ahead of the curve and be prepared for that next issue that will come across our states.
Yeah, predictive modeling.
Thank you, yes.
Developing scenarios where you can say, if this, then what can we do?
Governor, this is exciting. I mean, you know, who would have thought 10 years ago that we would hear governmental officials talking about predictive analytics, and here you are an advocate.
Well,
I love that.
And that's the way it's going. When you look at the HIMSS call to action for how a lot of these things are unfolding, you look at the trends that are out there, some of the issues that have cropped up already here. You know, IBM has Watson. There's a big trend toward blockchain as a way for identity management or records management, the integrity of the record, the integrity of the ledger. That's one of the essential things for healthcare. Then you look at all the data that's being assembled from Internet of Things, from wearables. People are taking more responsibility for their own health, from fitness machines to anything else.
Right.
How do you integrate all that data? And then how do you analyze that? So the idea of machine learning or artificial intelligence, those are the concepts that are just now starting to break on the scene that even 5 years ago people weren't talking about. And then you introduce cybersecurity, because when you assemble that much information, you have a lot of vulnerabilities.
Yes, Savannah, it sounds to me like what we're talking about here is a massive public-private partnership where everybody comes together, government agencies, hospitals, public and private, and industry, technology, et cetera. I mean, am I being grandiose?
No, I think you're right on point. I think the one thing that you discussed earlier is like, what's the federal stake in all this? And I think the federal government has sort of helped build a framework for how each state can do this, because not only do we have to do things internally within a state, we have 64 parishes in Louisiana. So what we've done around the opioid epidemic is take a look at visualizing where we have sort of the hot spots for deaths, for prescription practices, and so forth, and target our actions around where there needs to be treatment and prevention. But the next thing that we have to do is, once we do things within our state, how do we partner with the states surrounding us so that we can see that flow across states, so we know what's going on in Texas, Arkansas, Mississippi, and be prepared so that we can sort of do things internally, but be prepared to do it around our convening states as well.
And the other issue would be, how do you pay attention to the variety of demographics that are out there and the density or lack of density of population? You look at New York City or Los Angeles, LA, you know, but how spread out it is. I spent 5 years out there with the space program, and I'm in Wyoming, where the average density is 6 people per square mile. You know, it's barely within eyesight of each other.
Right.
You have to figure out ways where you can provide that kind of coordinated care for a wide range of populations. They might be vulnerable populations, such as the elderly or poor that don't have access to care. And the whole issue of treatment for opioids, what's the demographic that's most likely in your community to be hooked on it? In Minnesota, it was 17-year-old girls on heroin. Up in the Northeast, I think it was predominantly black males of a certain age. It has no stereotype.
No.
So part of what you try to gather with what they've done in Louisiana is say, where is it happening, why is it happening, who is it happening to, now how can you trace up what to do from there?
Well, Governor and Doctor, thank you for leading the charge on your committee. We appreciate it, and we're certainly look forward to hearing from you.
Thanks for the opportunity.
Thank you.
Appreciate it.
Thank you. What if you had a chronic illness, you had multiple doctors, and they all talk to each other, and they all share your data, and you don't have to worry about how they share your data? It might actually be happening in the state of Michigan, where they're making it easy so you can focus on just getting healthy. Brian Mack is manager of marketing and communications at Great Lakes Health Connect, and he's joining us now to talk about what's happening in the great state of Michigan. So you might actually be already solving this whole information sharing issue.
Yeah, well, certainly we are getting through the curve, and there's, I don't want to oversimplify it, but I feel like we're well on our way to getting to that point. And Great Lakes Health Connect, in my opinion, is a good model for a means of our arriving where we want to be.
And describe the model for viewers who are listening and curious, just so they can understand how it works.
Sure. So Great Lakes Health Connect is the premier health information exchange in the state of Michigan. We connect 129 hospitals and about 4,000 primary, specialty, allied, and ancillary care providers across the continuum of care. So that's everything from behavioral health to long-term care, county health departments.
Again, integrating all these different doctors that you might need if you have a serious chronic issue.
Exactly. And the mandate that we have is that we want to be able to deliver critical patient information to the provider on behalf of their patients in real time, where and when they need it to inform the quality of care.
Gosh,
and that's happening right now.
What a difference. I was speaking to a lady earlier who's become a patient advocate. She's had lupus for 35 years, and she says she has to manage the disease herself. She wants to just get healthy, but she's worried about bringing data to the different doctors.
Right,
and that's what we're talking about.
That is the crux of the issue. That is. So you're speaking of Amanda, who's a friend.
Oh, you know her?
So I do. So she's terrific. And part of the challenge is that from state to state, the infrastructure for health information data sharing is different from state to state. That's one of the dynamics that makes this so challenging.
And God forbid you move.
Exactly. And so it's different for everybody. The goal that we are pursuing, and I think the place that we are starting to get toward in Michigan today, is not having to worry about hauling that binder of your own health information around with you, at least all over the state.
So the key to that is obviously opt-in. You said, what, 4,000 doctors, 100 some odd hospitals? I mean, they all have to
That's right. They have to be, they have to be on board. And so we are, I think there are 131 different hospitals across the state of Michigan today, and we connect about 129 of them.
Wow.
And now
that's pretty darn good.
It is pretty darn good. There's a difference between breadth and depth. So we have terrific breadth, and we are continuing to move forward on our depth of solutions. So there might be a very rural, small rural health practice that is just connecting for their meaningful use requirement. And then we have some of those larger urban health systems that are doing a deep dive and doing some very advanced analytical kind of work with us.
All right, so, gosh, I wish we had more time. We probably have about 90 seconds, maybe 2 minutes if we both talk fast.
Okay.
A hospital says, yes, I want in. What do they have to do?
They basically connect with us. That is what we do. We do the integration, we do the
It's all via the cloud. You drop the software in via the cloud?
Depending on the solution. So some are cloud-based, and more of those are moving toward the cloud every day. Some of those are, though, they're housed, data center housed. So it just depends on the solution that they're interested in.
And then the people at the various healthcare provider have to go through some sort of training to learn the system.
Yep, and we provide all of that, and all of the connectivity is all seamless. It's all handled by our team.
And I would imagine all these pieces of data are in discrete little boxes, like the old D-base formulas we learned in college and high school, right?
Yeah, well, I'm
maybe junior high if you're a geek.
I'm the marketing guy, so I get in over my head on the technical specifics very quickly.
But you can pull up little bits and pieces of the data.
This is exactly right. Yeah, that you can specify. Health information exchange is quickly moving beyond the query and retrieve basic equation and moving into much more complex applications of that information.
Sure.
But fundamentally, you're absolutely correct that you could theoretically ask for a piece of information and have it pulled back longitudinally.
I would imagine a lot of people here at HIMSS want to talk to you. Quickly, how many other states are doing what Michigan is doing as successfully?
Yeah, there are many across.
There are many.
There are many
across
the country. It really does. The challenge is that the states are in different places based on their individual regulatory environments. And it makes it challenging when you talk about interoperability and knitting the entire nation together.
Right. A word, by the way, interoperability, we're still all trying to define because it's a work in progress.
Correct. Yep.
Gosh, Brian, thank you so much.
My pleasure. Thanks for having me.
Thank you.
You bet.
All right. Adrian Bossi is Chief Experience, how do you like that? Chief Experience Officer at the Cleveland Clinic, certainly a leader in so many different ways. Here's Dr. Bossi.
Hello, I'm here with Adrian Boise from the Cleveland Clinic, and thank you so much for joining me today.
Thanks for having me, I'm thrilled.
Good. So tell me a little bit about your session.
So we kicked off a session talking about how do we make the human experience more humane and tech disruptions that should really make that happen. And if I had to encapsulate it in 30 seconds or less, I would say we really need to be thinking about the moments that matter most to patients and actually designing for them, which sounds like a great global statement. And to be more specific, there are things that matter to patients that we're not designing for yet. Let me give you an example. You come to the outpatient clinic and you wait just like you've waited for the past 50 years.
Sure.
That makes no sense to me. That needs to be completely disrupted. We need to know you've arrived in the garage. We need to geolocate you. We need to welcome you with a text or the way that you prefer to be communicated with. And we need to manage your expectations around when you're going to be seen on an ongoing basis. And when we fail at service and those types of things, we need to be able to successfully recover it. Those are the types of things that drive patients crazy,
Sure.
and we have to be designing for.
So how do you identify those areas, obviously? Because over time, you're right, when I look even at my own life, a lot of it has not changed in that industry. So what are you doing to find ways to really disrupt and identify those?
It's kind of amazing, isn't it? Right? Like you could still walk in and see the sign that says, if you've been waiting longer than 15 minutes, please come tell the front desk. Like it's your problem that we're late and not telling you. It drives me crazy. So I think there are a couple of sources of data. You know, everybody talks about HCAHPS and CGCAHPS as patient satisfaction surveys, but patients, the richest data that actually comes from patients is when they write us letters. We get thousands of unsolicited letters that come in the form of either compliments or complaints about what we do in healthcare. And I can tell you, if you haven't spent time reading those letters, please go do that immediately as soon as you get home, because they're filled with a richness around a patient's journey, which is something that we don't have the privilege of seeing. We see a snapshot, right? My sliver of registration, my sliver of the doctor-patient visit, my sliver of discharge. And yet for the patient, that's a continuum that they experience with us. And so often they write in single-spaced paragraph form, sometimes even handwritten, about how that made them feel. And in healthcare, I'll tell you, if people walk away feeling like we didn't care for them, we absolutely missed the mark.
Absolutely. That's interesting, because I know people must feel obviously incredibly passionate about that. So tell us about some of the results that you've seen.
Well, you know, people also, I hear a lot, sometimes when we compare patients to consumers, right? Like they're the same with the same capabilities. And I guess before I answer that, I would call out, they're not the same, right? If I go to Target to buy toilet paper, I know exactly how much it costs.
Right.
I can get in and out. I know where my service is located. And then, right, I might get a survey that follows up with me to see how that experience was. In healthcare, though, once you become sick, something changes. And it's not just one thing that changes, right? I don't have cost transparency into the service I'm getting. I don't get regular updates or emails. You're not using any of my prior experiences to inform my new experience. Vulnerability and fear, I think, go up. You lose control as a patient. And for me, that's really important distinction.
Yes.
Because if you just found out you had breast cancer, you just found out you have ALS, right? It's not the same as going to get a service that you want.
Yes.
Nobody actually wants the services that are offered in healthcare, just in case you were wondering.
Right, and that's a great point.
For the most part. And those crucial differences matter a lot. And so I think one of the most important things that we've done is really try to map out the emotional journey that our patients have and design for those pain points. So when you're trying to access care and you can't figure out how to get a hold of your care team, or you don't know the right doctor for you, that's a real problem at a point where the patient is feeling most vulnerable. And so we've done a lot of things like create 24/7 access, design access anytime, anywhere, on any device, so that patients can see anybody literally anytime. Wow. Make it easier for them to connect with their care team through patient portals. We don't do optional roll-in, you're automatically enrolled, and then we engage you through that portal. And then lastly, dramatic changes both in the discharge process as well as in the billing even. Wow. Because these are the pain points that people have. And honestly, our job is not just to reduce, there's a lot of suffering that comes with having a disease or a chronic condition. And these, if we don't address these pain points, we're adding on avoidable suffering, which to me must be eradicated.
Absolutely. So I think you're doing some amazing things. Thank you so much for joining me today.
Boy, are we trying. Thanks for your time.
Sounds like it. Thank you so much, everyone.
All right, it's time to meet one of our own, Michael Nussbaum. He is executive lead of Olympic Healthcare Interoperability Initiative. And I should also note the first Canadian on the HIMSS board. Congratulations,
and
sir.
Proud to be.
I don't know why they waited so long.
Me neither.
All right, so
thank you.
You are leading the effort to do something that has never been done before, and that is to bring the capability of modern healthcare delivery and the exchange of information to Olympic host cities. It's an amazing concept.
It's an amazing concept. It's not complicated, but it hasn't happened yet.
And explain why you're doing this, because it's so beautifully simple.
There is an entire health infrastructure that comes to each host city of the Olympic Games in order to take care of the athletes, of the coaches, and what they call the Olympic family members and trainers, etc., plus the tens of thousands of volunteers, plus spectators.
Right.
So there could be 1 million people that descend on a host city. And
God forbid one of them gets sick or breaks a leg.
It's likely that somebody is going to get sick. As a matter of fact, about 10%, it's been proven that about 10% of the visitors and the athletes will hit the healthcare system in some way. And the host city, of course, doesn't have the capacity to handle that.
Right.
They've got a pre-existing health environment that is set up for its citizens. So, so the International Olympic Committee takes responsibility of making sure healthcare services are provided during the Olympic Games.
It sounds so simple and so obvious, but it would never have occurred to me. It's amazing.
So what we're trying to do is augment the facilities that are planned and going to be established with interoperability. And interoperability is what we do here.
Sure.
This is where we've been working for years. The HIMSS supports an interoperability showcase dedicated to showing what can be done with interoperability.
That's really the whole message. How do we get systems, people, organizations to better communicate and to share data so that patients have a better experience?
So the objective, of course, is that information follows a patient no matter where they are in the system. And the system theoretically, and the system is put together by a bunch of different stakeholders. The IOC, the local organizing committee of the Olympic Games for the host city. There's contracts with lab services, with pharmacy services, and there's contracts with local tertiary referral hospitals that all participate. So the system now, all of a sudden, is a bunch of different silos, each with their own technology, but without interoperability.
And in a foreign country.
And always
in a different language.
And there's foreign countries every 2 years.
Yeah.
And the Olympic Committee, the Olympic teams that come from, say, 200 countries around the world, all come with electronic or with health records. Many of them are coming with electronic health records, and in the future, they will all be coming with electronic health records.
Yeah, and I would imagine it gets a little prickly when, say, a Russian teammate gets sick in a different city.
Exactly. So there's language issues, there's there's all kinds of cultural issues, etc.
Sure.
So we're trying to use and leverage international standards for interoperability to solve exactly that issue.
Amazing.
And all of these countries are in fact participating actively right now in that.
So 2 years from now, the world will descend upon Tokyo, which is actually a city that probably can handle a lot more than most. What are you working on to make that happen?
Well, we're working with the officials in Tokyo, the technology organizations in Tokyo, and with the Tokyo Organizing Committee to decide how we're going to begin our implementation of interoperability. Tokyo is going to be something where we're going to start small. And as we move between all the different Olympic Games in Beijing and then Paris and all the way through to LA 10 years from now, we're going to incrementally increase our reach. And by the time we hit LA, that's our end goal, we're going to have a fully implementable, interoperable healthcare environment. That's the plan.
Do you think there are lessons? I mean, it's almost of course the answer is yes. But so let me rephrase it. What are the lessons, do you think, that might come out of an opportunity to interact with Japanese healthcare? You've been studying this for 18 months, haven't you?
Of course. Yeah. And not only we're studying in Japan, but also in China at the same time. So we're dealing with all of them.
Sure.
Each host city has its own nuances. There's different ways that healthcare is provided, but all of the countries that are participating as host cities and around the rest of the world are all focused on the same thing, which is a ubiquitous way of patients from wherever they are in the world to get the healthcare services and have the information follow them wherever they are in the world. So we've been working on this for a decade. And so this is a great microcosm of a whole international environment that we can actually run every 2 years.
Now, I'm going to go out on a limb here and guess, and you tell me yes or no, that because it's the Olympics and all the goodwill that comes with that, there's more buy-in, right, than if you were just trying to go go down the street here in Las Vegas or in New York City and get someone to do the same thing?
Well, it's clearly the right thing to do, but the Olympics, what the Olympics offers, and obviously it's an important piece, is high visibility.
Yes.
High visibility. So when the digital health industry of the world comes together to facilitate interoperability at the Olympic Games, you can be sure that it's in the interests of all of the participants of the digital health industry to get the message out that look at all the good we can do, and we can do it for the Olympics, but we could also do it for you.
Yeah, exactly.
Right.
It's a brilliant platform. It's a way of getting the message out. Who have been some of your big partners that are enabling this to happen?
Well, HIMSS, for one, has been fantastic. We've been working with HIMSS for the last year, and together with HIMSS, we've been working with SNOMED International, which is, both of these organizations are international in scope. They're leaders in digital health, and they have come to the table with strong support, financial support, in-kind support, and probably is the reason I'm here talking to you.
Yeah, well, so Michael, it's such a pleasure. I get excited just talking about it. Everyone loves the Olympics, and to use this as a way of furthering interoperability, I mean, it's just amazing.
Absolutely. Well, that's our intent, and we're glad you're participating.
Oh, well, thank you. Thank you for having me as part of the community as well.
Thank you, Adam.
All right, Michael. Manish Shah is Senior Vice President and Chief Information of Community Health Systems. You talk about trying to bring together lots of people under diverse umbrellas. Well, here you go.
The journey for me actually was to try to figure out and understand how organizations in healthcare are thinking about unlocking patient experience and how they become relevant in the care and the continuum of care for patients before, during, and after. And what I heard this morning as a kickoff from SEMA was actually refreshing, that the administration shares in that value of unlocking the patient data and putting the patient data at the forefront of their care. That entire decision process will really lead to what's called the Blue Button Initiative. And I'm really looking forward to organizations that are represented here integrating the Blue Button Initiative into their products and unlocking the data that for so long has been locked up and not been really used in a valuable way that can drive better patient care. So for me, I think it's really exciting time in healthcare that we're thinking about consumerism, we're thinking about the patient first, and really HIMSS 18, for me, states that this is the beginning of that journey and a commitment by the administration that they are willing to participate in that. So I'm really excited to see what the world evolves into as healthcare transforms to consumerism and patient delivery and patients at the heart of how we do things in the future.
Michelle Lair O'Connell, MPA, is the Clinic Director of the Rosewood Family Health Center, Yakima Valley Farm Workers Clinic. Michelle, thank you for coming here to Las Vegas and telling us what you're doing in Yakima.
Yeah, that's great. Thank you for having us, or having me. So we're here to talk about the screening that we're doing for social determinants of health and building a data asset with Yakima so that we can better understand our patient population, utilization trends, and provide better care for our very vulnerable patients.
And how receptive are people when you say we want to collect a bunch of data on you?
Right. So, I mean, the questions that we're asking, so we're asking questions about things like poverty, housing insecurity, trauma, isolation. They're very sensitive questions.
Yes.
And they're hard questions to ask, and I think hard questions for folks to answer honestly,
sure.
Unless we have an established relationship. And so one of the things that is going into our project is making sure that we're involving patients in developing the process and developing workflows and talking about how they want to be asked these questions.
Yeah, it's sensitive.
Yeah.
It really is.
But I think as a primary care practice, we have a unique relationship with our patients and the ability to ask questions that that they might not be,
sure.
as comfortable answering, in other situations.
Well, the conversation we're having, it suddenly brings it home. You realize patient-doctor privilege and the intimacy of that relationship is paramount. I mean, it really matters.
Yeah.
And you really have to honor that. How comfortable are people knowing that some of this data is now going to be put into a database and analyzed, shared, compared with other people?
So that's a really good question. I think, it varies person to person. Some people feel, very comfortable with sharing their information with the doctor's office. There are some people who feel less comfortable with that. But one of the things that we work on doing is talking about why we want this information. So we know now that social determinants of health, things like socioeconomic factors, health behaviors, the built environment, that those actually have a much greater impact on overall well-being than access to medical care.
Can you actually quantify it for me?
Sure.
I'm dying to know.
Yeah.
I'm an economist by training, so I love numbers.
Yeah, so I'm not going to be able to cite the source off the top of my head.
Okay.
But when you look at kind of a pie of what affects health behaviors, about 10 to 20%, depending on the source, say that access to medical care does. But health behaviors and socioeconomic factors take up about 60% of that, with another 20% being the built environment. So the space that we're living, communities, parks, access to supermarkets, access to safe streets where you can play and get outside and exercise, things like that.
Well, coming from New York, I can tell you about some of the studies done in the Bronx. Why is it that only 56% of high school students in the Bronx graduate? And then they started doing all sorts of correlations about waste removal, and so much of the city's waste gets funneled through the Bronx. And you have clogged highways, and that creates all the exhaust. And you start adding all that up, and it takes its toll, and then that expresses itself in lower graduation rates.
And I think the important thing for us in asking about that from the primary care perspective is that when our providers are working with patients on care plans, it's really important to know what's going on with that individual. We are a federally qualified health center, and we serve a very vulnerable patient population. We have many people who are homeless, living in the streets, who are living in, living on couches. We have people who don't have access to fresh foods to support their health. So if you have a diabetic patient who is homeless, who doesn't have a place to store fresh fruits and vegetables, the care plan that you develop with that individual to help them improve their, diabetic outcomes is going to look very different than for someone who does have access and space for that. So it's very important for us to understand all of the factors that are going on with our patients' health in that process.
How do you deal with undocumented immigrants?
We see anybody regardless of their status. Our clinic was actually founded to work with agriculture workers in the Yakima Valley in Washington State, and so we specialize in working with that population and have a very deep and trusted roots in the community.
And will that population let their data go into databases?
So we don't collect any information on documentation status, and because we've had more than 30 years of working with this community, they do trust us, and we do have that, and they understand that it's very important to tell your doctors what's going on, so that they can help take care of you and support your care. But it takes a long time to develop that trust.
Oh, of course it does. And for security behind it, are people coded with random numbers, or is it their names when relevant social security? How is each person stored in your database? So
we have an electronic medical record that we use. And so we have, when patients register, we collect some information. We don't collect social security numbers. Like I said, we don't collect any information around documentation. We do ask for information around income and housing status so that we can understand what's going on with our patients. But really, that information is confidential. It's part of the confidential medical record, so we don't share it with anybody.
Well, it's wonderful to see that we are striking a balance. Thank you so much for being here.
Yeah, thank you for having me.
Very powerful conversation.
Thank you.
All right, talk about powerful conversations. Sarah London is the Chief Product Officer at Optum Analytics. You've heard me mention this company a number of times over the course of the past couple days. Optum Analytics, really on the forefront of so much that's happening here at HIMSS, and certainly a proud partner of HIMSS. All right, Sarah, tell me all about Optum IQ.
Sure. So we're really excited to be highlighting OptumIQ at HIMSS this year because in addition to talking about all of our products and services, OptumIQ is really something that is infused into everything that we do, and it is a way to talk about capabilities that we've been building over a long period of time, but we're now at a point that by bringing those together, we can take the solutions that we offer to the market to a completely different level.
In other words, the analytics that had governed payer relationships can now be applied to patient relationships.
Absolutely. And if you think about the work that we've done for the last decade to curate 100 million clinical lives, if you think about the work, think about Pandora, right? And the fact that it can offer you great musical selection based on the kinds of music
and how's
you
it
like
know
to
I like those
listen.
songs?
Because, right, and they spent
Right.
a decade actually annotating and curating the data around music, and
Right.
that's homework and gritty work that Optum has basically been doing for 10 years that no one else has done. And now that we've done that and that we have done all of this work to develop analytics on that, we can actually drive to the next level, which is starting to not just be descriptive about what's happening in the system, but really be predictive and then actually be prescriptive. So if we are talking to a patient, we can say, because of everything we know about you, we see all your data. Not only here's what we think you need to do to stay healthy, but here are the recommendations we think you're most likely to follow. And so the interaction is just such a higher value interaction for the consumer.
What enabled us to go from just collecting data to analyzing data to now, as you just said, predicting what might happen in the future, predictive analytics?
So first of all, a lot of hard work
right.
and a real focus on that. But the way we think about OptumIQ is it's really three core components. So it is that curated data and then using that to build analytics, but it's also the applied expertise. So we have 25,000 subject matter experts in Optum that work across the entire system and are able to bring a knowledge of how things work and how things could work better to lever the data and the analytics to actually tell a different story.
So pick a disease and walk me through how you'd approach it on these three different, I don't want to say silos because that implies they're walls, but three buckets. Diabetes, obesity, et cetera. How would you attack diseases like that across the spectrum?
Yeah, great question. So if we start with the data, so one of the things that's fascinating is if you look at the data that we collect on patients today, even in electronic medical record, which is 80% of it is non-discrete, and then above that, when you actually do the work to pull that data out and codify it, what you find is that somewhere between, for most providers, somewhere between 30 and 62% of diabetics go unrecognized in the system. Because the doctor makes a note over here, they don't actually code it, the payer doesn't know about it, they may not even have a conversation with the patient about it because they might not be talking to the patient about diabetes. And so what happens is we're able to develop algorithms that comb that data and say, this patient is actually shows all the clinical indicators of a diabetic, and we're able to serve that up to a provider to say, is this someone you should be treating in a different way? And then what happens is you go from having a patient who is unrecognized and not treated, who ends up going to the emergency department because they have a diabetic issue, they're not managing their obesity, they have depression, their utilization of the system, their patient experience is horrific, to a patient that gets proactive outreach from a provider. Someone says, we're going to hook you up with a nutritionist, we're going to get you on the right medication, we're going to talk to you about how to manage this disease. This is not some, terrible, you're going to, you're going to have like an awful experience for the rest of your life. This is something you can manage through. And from a patient perspective, it's a completely different experience. And from a system perspective, you end up driving down the cost of that patient's experience with the system, so it's a win-win.
So there are a couple of sort of follow-ups that come into my mind. Number one, if it's data dependent, that means it's patient participatory dependent. Patients need to go to the doctor and they need to have regular tests so that there is data to evaluate in the first place. Is that a new mindset?
For patients or for the system?
Well, I mean, both. I'm a terrible example. I go to the doctor when I get sick. I never do preventative stuff. How do we change me? How do we make me embrace going to the doctor and taking better care of myself?
That's a great question. And I think the neat thing about having done all the work that we've done on the data that we have is that knowledge allows you to start to pivot out to data sets that are thinner where you can kind of infer things. So one of the big pushes around the power of OptumIQ is driving out to the consumer and saying, what are the data sets that we can collect about you that actually sit outside of healthcare, but tell us what your habits are that may actually help us predict when to bring you into the system. And so one of the things that that Optum is doing within our Optum Ventures arm, which is also very tied into this idea of kind of how do we elevate data analytics and expertise in evaluating up and coming companies.
Right.
We have a company called MindStrong that has developed a capability where just by the sort of passive interaction with your cell phone, it can tell whether you are depressed. And so,
come on.
Yeah.
You mean like, do I bang the keys hard, or or am I apathetic?
So
that's amazing.
So it allows us to actually get to a place where we not only can reach out to you, right, but we can also bring a different level of value to you, so that your interaction with the health system isn't just when you're sick, it's value that we can bring to you to keep you healthy.
All right, so this now gets to one of my follow-up questions, which is, once you have that information, or at least you think that there is a diagnosis starting to take shape, I'm depressed, or maybe I'm at risk for diabetes, how do you tell me?
Yeah.
That's a tricky one.
Yes. So that happens a couple of different ways, and a lot of it has to do with our relationships in the market, right? So we create this, so the products that we bring out, for example, to the provider systems, right? So being able to give them the knowledge at the point of care within their EMR, right, or a notification that this is a patient who seems to have evidence of a disease and needs an interaction, that we make them a much more powerful actor in reaching out to the patient.
The doctor. So
Yep.
the onus is really on the doctor.
Well, so that's one, but I think we're also getting to a point where, I mean, the fascinating revolution that I think is coming in healthcare is everything sitting around the consumer, right? And so that's where, as we think about developing the capabilities of IQ, going from the big data down to the small data, down to that one patient, how do you kind of organize a system around the patient in their normal life? So we have a number of digital capabilities that we've been developing that reach directly out to the patient and give them the ability to engage at whatever level is right for them. And so for some people, you need to have that conversation directly with a provider. For some people, they want to start getting information earlier. So Rally Health is a capability that we've built that uses the data, the analytics, the expertise on a digital platform to reach directly out to the patients and create kind of a tiered engagement strategy.
You make me want to go to my doctor. It's great stuff. Sarah, thank you. Congratulations on OptumIQ. It's an amazing product.
Yeah, thank you.
Government getting it right. That might not be a headline you read on the New York Times, but it's certainly something we're talking about here at HIMSS. Government partnering with institutions, with businesses, on behalf of patients, and improving care. That's called getting it right. Governor Jim Douglas, former governor of Vermont, joined Dr. Daniel Morenheim, State Delegate District 11 from Maryland's House of Delegates, as well as Jesse Topper. He's from the 78th District, Pennsylvania House of Representatives. I had a chance to sit down with these three gentlemen. Again, government getting it right. Let's listen. We are so excited to bring you a conversation that may go down as one of the best here at HIMSS 18. We're joined by three gentlemen who are not only passionate about healthcare, they are also politicians at the forefront of trying to get this thing right. Governor Jim Douglas, I should say the former governor of Vermont, joins us. Delegate Daniel Morenheim, who's actually a practicing doctor, an emergency room doctor, is a state delegate, District 11 from Maryland in the House of Delegates, and Representative Jesse Topper from the State District 78 in Pennsylvania. Gentlemen, what an honor to be with all of you. Thank you.
Thank you.
I love bringing public and private groups together because I feel like there's this incredible opportunity to create partnerships, and it's the sort of thing that we always dance around, but somehow we never get it right. But maybe this is an opportunity where we can start bringing people together, healthcare, right? Patients, doctors, and now government. Governor, if you could talk about some of what you were part of up in Vermont, because Vermont has a much more public-private willingness than so many of the other states.
Well, we try to encourage that, of course, and it was about a dozen years ago that we put together an organization called VITAL, an acronym for Vermont Information Technology Leaders, to bring, as you suggest, the private sector together with state officials to work on HIEs, patient records, and interoperability among those data. It's still a work in progress, to be sure, but because of the small size of our state, the close-knitness of our communities, we have an opportunity, I think, to really make it work. And for not only that reason, but some others, we've been deemed in the last decade the healthiest state in America for quite a few years.
Vermont is the healthiest state?
Well, not this year, but on my watch.
It might be the most beautiful state. Under your watch, yes, it was the healthiest.
So we think we can continue to make some progress. As you know from your experience on the slopes of Stowe, it's a place where we value recreation, outdoor activities, living a healthy lifestyle, and if we can use data to facilitate the healthfulness of our state, I think it's going to be a very successful effort.
Yeah, Congressman from the great state of Pennsylvania?
Just representative. I don't need to get the promotion.
Okay, well, we'll give it to you if you want, but I appreciate the honesty. What's brought you to HIMSS?
We were able to have a bill a couple years ago that allowed Pennsylvania to join the Interstate Medical Compact, so allow our physicians to be able to practice telemedicine across state lines, which in an area like mine, a rural, underserved area, telemedicine is the future. It's what we need in terms of having accessible and affordable health care. So I was really excited that we were able to work with HIMSS, get that legislation passed. It was passed unanimously in the House, the Senate, signed by the governor. Not too many bills that can do that anymore.
Nothing ever happens unanimously.
Right. We were excited about that and the opportunity that telemedicine provides, not just for our constituents, but also for surrounding states that use our facilities. The great Children's Hospital out of Pittsburgh, Children's Hospital out of Philly, Lehigh Valley Network. We have wonderful facilities in Pennsylvania, and we're happy to export that as healthcare as well.
How hard was it to cross state lines in what you were doing with that?
It's hard, and it's still hard. We're still dealing with some issues with background checks with the FBI that we're trying to get right. Have a meeting with the Attorney General's office next week just to try and make sure we're able to actually get these expedited license out there so that doctors can practice across these, what I call imaginary barriers, but they're still great barriers.
We drew them, but...
Right.
Yeah, but if we can redraw congressional districts, we ought to be able to redraw lines to help people.
Right now, yes.
Yeah, that's not going so well either right now.
That's right. Well, yeah, we got to have some fun with that. Doctor, you're in a unique position because you are both a member of the state legislature in Maryland and you're a practicing emergency room doctor. What's that perspective like for you?
Well, I try to bring both together because at the end of the day, the whole purpose of the health information system, and HIMSS is just amazing, by the way. I'm so impressed and met so many interesting people. But the whole purpose of it is to facilitate the transaction between the provider, doctor, nurse, social worker, whatever, with the patient. And so you really want to have all the data there easily, quickly, and in a usable way, because we're spending, however, a little bit more time on the computer that I would like, than most of my colleagues would like, and we'd rather be focusing on the patient and using the data to facilitate a meaningful dialogue where there's time and space in order to engage in good conversation. So I've tried to bring a clinical voice to this discussion as well.
Dr. Madeira of the American Medical Association, the CEO actually, commented to me yesterday. He said on average, the AMA has found that doctors spend 2 hours of sort of back room work for every hour with patients. Has that been your experience as well?
I think that's generally true. It's different in the different fields that you're in. Emergency medicine, I work at a big urban trauma center in the middle of Baltimore City when I'm not in my legislative duties, and every patient is new. So if we could get more information about them, whether through the prescription drug monitoring program or the medicines they're on or their past history through the health information exchange, it would greatly facilitate care. But the other point I would make is I'm also the one, or me generically, are the ones who actually enter the data. And there's some real issues.
Should you be doing that?
Well,
a talented doctor? You studied for 14 years? I mean, aren't there people who can input the data for you?
No, because of the way the charting systems work, somebody has to review it in the end and make certain final decisions based on ICD-10 codes and other kinds of things, which drives the data that others use not only for billing, but for public health decisions. And I will tell you candidly that there's a lot of issues with that. Not because we don't care, but because the system is very difficult to use at times. And that's why you hear things like 2/3 of the time is spent on computer time and one third of time spent with patients. That should be flipped.
Governor, I see you leaning in as you're listening.
Well, exactly. We want to make it as efficient as possible. We want to transmit the data across state lines, and I think the work that Jesse and his colleagues have done is critical. The Interstate Compact is pending in the legislature in Vermont now. I often note that the second largest hospital in Vermont is in New Hampshire in terms of the number of patients, and so we have to break down those artificial barriers, as you noted, Adam, and make this more possible.
I just want to remind all of you out there we're listening to and honored to be joined by the former governor of Vermont, Jim Douglas, Delegate Daniel Morheim, State Delegate District 11, Maryland House of Delegates, and Representative Jesse Topper, State District 78 in Pennsylvania. Again, gentlemen, thank you. We're just so excited that you're here at HIMSS this year. ACA has gone through so many different changes, and I think we're all trying to figure out in real time, but ultimately, what do the changes that are, again, happening in real time mean for patients? And Representative Topper, if you want to try to address that, how's Pennsylvania dealing with the shifting macro scale of ACA?
As a member of the Health Committee, we're dealing with it really almost every year since it's been passed, and there's tweaks that go on. And the unfortunate thing about working in the state, as these gentlemen can attest, is a lot of times we're reacting to what happens at the federal level. And with so much flux at the federal level, it's been very difficult. But we try and do the best we can with the information that we have and make sure. I think one of the biggest things we've tried to do is make sure our constituents are aware of the changes going on at the federal level, and then trying to provide them the information with how that will most likely affect them. But it's difficult, and I would say anybody who says that they have an idea of exactly where it's going is probably wrong.
No, I don't think anybody does, including those in Washington. Do you think it's easy, and I'll lob this out for whoever wants to answer first, do you think it's easier for states to tackle these issues rather than the federal government and go directly to payers and providers?
Well, in many cases, and I'm glad that states are represented actively at HIMSS now, because so many health decisions are really state decisions, not only participation in the Affordable Care Act, but everything from Medicaid, hospital regulation, insurance regulation, all the licensing and provider issues, including the Interstate Compact, sexually transmitted diseases, medical cannabis, medical marijuana, end of life, reproductive rights and abortion. All those things end up being state issues. But I do want to make this point. Whether we have, at the end of the day, a national single-payer system or everybody's on their own, there are core clinical drivers that drive healthcare. Emergency rooms where I work are the source of 80 to 90% of hospital admissions. That's where people get in the hospital.
Is that a good thing or a bad thing from your point of view?
That's the way it is. Oh, it's a good thing because we got a lot of stuff out of the hospital, but elective surgeries, but people end up, that's where the decisions are made to put them into the hospital, and there's some strategies that can reduce that. I'll just give you a few very quickly.
Please.
End-of-life care.
Right.
If people would complete advanced directives, free legal forms, that would make a huge difference. Addiction issues make a huge difference, not only in healthcare, but crime. 80% of crime is addiction-related in the United States. Obesity and lifestyle. People got to get in better shape. We have too many diabetics. Preventable trauma. The demographic now is an older woman living at home alone, falls down, breaks her hip. When I started as an ER doctor, I saw a lot of people from fender benders with injuries. We don't see those now because we've got airbags and safety seats and baby carriers and all that stuff. So there's some strategies to identify what's going on in the community. Regardless of the payer mix, you're going to have to address these core clinical drivers of healthcare.
And Representative in Pennsylvania?
Well, look, let me be very clear. Unless it's foreign policy, national defense, or infrastructure that crosses state lines with roads, the states can do it better, and we should be doing more of it.
I have the honor and perhaps the challenge of serving as chairman of the National Governors Association when the ACA passed. And there was a lot of concern on the part of governors across the political spectrum that the federal government was bringing its heavy hand into this area that has traditionally been the province of the states. Obviously, they are a significant payer through the Medicaid program and Medicare. But I think, as was famously said, the states are laboratories of democracy. 4 years before the ACA, we passed a bill in Vermont that ultimately reduced our uninsured rate by 1/4, and we did it on a bipartisan basis. So I think states really can get the job done.
And we did that too in Maryland on a bipartisan basis. In fact, we had Republicans defending the bill on the floor of the House, even though it was a Democratic majority, but the Republicans felt strongly enough about it.
Well, patient rights, that's certainly something where everyone can get behind. Gentlemen, I wish we could keep going. This is We can't tackle this possibly in 12 minutes, but unfortunately it's all the time we have. Doctor, Governor, Representative, thank you.
Thank you. Thank you.
All right. Shattering the glass ceiling and doing it right here at HIMSS. We're talking about women in IT. We had a whole session devoted to it. It was one of the most attended sessions here at HIMSS. We're talking about people like Nancy Green, Global Practice Lead of Healthcare and Life Sciences at Verizon, Kristen Venom, America's Advisory Health Sector Leader for Ernst & Young. So many different attendees. We had a chance to listen in and then speak to some of them.
So a gender diverse workforce in health IT is important because really the perspective that it brings, right? So we're very different people across gender, age, and so that diversity brings quite a bit of conversation and is able to add to where we're moving the industry.
A diverse health IT workforce is important because it is really important to get different perspectives. Different perspectives inspires creativity, and both perspectives and creativity then really helps to achieve innovation, which is what is truly needed for us as we move forward with the challenges that lie before us in healthcare. And if we think about within healthcare IT, has been predominantly male-dominated in the past. So in order to really, I think, inspire, get the creativity that we need to, infuse more women and women leaders within health IT.
So the women in health IT, for us to grow and prosper, we need to help each other and be able to talk with and create the conversation to be able to do that. And as we do that, so within Verizon, we have a very large organization that's supporting women, specifically in IT, because as an IT company, it's important to us. And because that diversity and the perspective is added, it gives us an edge, and that's what we try to support for women in health IT as well, is to bring them up throughout the organization.
EY supports women in health IT and women in diversity in several different ways. We have the Women Fast Forward program, which really focuses on women through mentorship, sponsorship, and coaching. And we also have a program, too, that is called Early Conversations. And this is actually both for women and for men. So we start those conversations early with our workforce to help provide the right support of sponsorship and mentorship to help them grow and advance within their careers.
So I think, the question really is, how can we help support equality, right? So whether it's pay equality or just equality in the things that we're doing. And I think it starts at the top, and the top really working through the entire organization in a concerted way, so that the unconscious biases that happen are looked at and the diversity in the organization is looked at, which then kind of level sets that pay piece. But you have to start at the top. You really have to look at it from the top.
Senior leaders, I think, in order to advance their workforce and to be aware of diversity, is one, they need to understand and be committed to the importance of diversity. And it comes to understanding and having the right information about bias, whether that be conscious bias or unconscious bias. And I think particularly thinking about unconscious bias at the individual level and understanding as an individual, where are your biases? And what are those unconscious biases that you may be exhibiting, and so that you can actually make some conscious decisions to change that as you move forward.
Earlier, I was able to speak with Dr. James Madeira. He's the CEO of the American Medical Association. Of course, you know who he is. He's really a spokesman for the industry as a whole, argues on behalf of patients, physicians, and now some of what he's doing may surprise you. Looks like the AMA now is one of the most thoughtful investors in the venture capital community. Let's listen. Dr. James Madeira, CEO of the American Medical Association, joins us now. And as you know, the AMA is at the intersection of healthcare and technology as it carries out its mission to improve the health of the nation. Dr. Madeira, CEO of the AMA, obviously has been a leading voice discussing the physician perspective on the need for technology that works for physicians at improving care for patients. He's here at HIMSS discussing challenges with current technology, including the electronic health records that are contributing to increased burnout among our nation's physicians. But he's also hopeful that we can change that. He's hopeful about the future. And Doctor, I'm so glad you're with us. Dr. Madeira, it's an honor.
Happy to be here.
All right. So the AMA, such a massive organization, so important to the health of America. And as I understand it, you really have, you see it as 3 different arcs. Can you talk to us about what those arcs are and what their impact is?
So we've traditionally spent time convening and in advocacy. We continue to do that. But our 3 strategic arcs that are related to the mission are professional development, creating the physician of the future, starting with medical schools, structuring medical schools for that future state. We will then move on to graduate education. So the first arc is professional development. The second is chronic disease. 80% of our healthcare spend in this country is chronic disease, and we've moved in the last half century from predominantly acute disease to chronic disease, and yet we're structured more for the acute phase. We have to restructure and think about how we take care of this chronic disease that's going to increase in burden year over year. And then the third strategic arc is allowing professional satisfaction by providing tools and resources around physicians and patients to have them interact, spend more time together, and have that flow of data be more effective.
I mean, that's really what it's all about, isn't it? It's about doctors being doctors and putting patients first, and yet somehow it's all gotten so complicated that they end up having to, become data scientists somehow in the process.
That's exactly right. I mean, we did a time motion study showing that physicians currently, for every hour they spend with patients, which is the hour that patients and physicians find most satisfying, they spend 2 hours, 2 times as much time in administrative burden and data entry. And that's driving physician burnout as well.
Yeah, of course it is. How do we deal with that?
So one thing is we give better tools, better data flow. We have projects both in Chicago and an innovation studio in Silicon Valley that deal with better flow of data, better organization of data, so you don't have to pick and choose and look around records, that you have a data object rather than 70 data elements. And then also a system that allows data to flow in a liquid way, in a secured, blockchain secured, permission-based way as a utility, like every other multi-sided market has a utility, like the financial industry or the power grid. We need that utility for rapid, secure, permission-based, inexpensive clinical healthcare flow.
I can't believe you just said blockchain. I mean, there it is, the most unpredictable new technology out there, and you, the head of the AMA, are potentially embracing it.
Absolutely, and we just spun out a company from our innovation studio, Akiri, which is a blockchain secured information transport framework.
So the AMA actually is in Silicon Valley investing and doing what we usually think venture capitalists do.
Yeah, and I think what we add to this is there has to be sort of a physician intuition in the problem definition that we start around the patient, rather than having, there was a shirt, when I was at University of Chicago, there was a shirt that was sold in the bookstore that said, that's all well and good in practice, and in the back it said, how does it look in theory?
Right.
And we have started a lot of healthcare tools and resources in a theoretical way without defining the problem around the patient. And we think that where the patient exists is the truth of our healthcare system. That's where we have to pay attention.
Do you think we got away from that somehow in the, the 80s, 90s, when suddenly HMOs became these massive organizations and people got lost?
I think in part that was true. I think another part of that is physicians historically have paid attention exclusively to their knitting. They've been heads down in their practices, heads down with patients. and yet it's 20% of our economy. It's a major source of important work and consideration for employers, and we have to really have that voice be part of the problem solving, be part of entrepreneurship in America.
Well, I have to tell you, I've been so impressed at the eloquence of the various C-suite executives here at HIMSS who are formerly doctors. I mean, arguably, you're one of them, right? You were a pathologist and GI specialist,
yep.
and took the tract of trying to make a difference in a larger way.
Yeah, you know, I had this came to me. I was at a health economics program at Stanford, a small group of us for a couple of days, and the person beside me said, you know, he wishes there wouldn't be enough positions in healthcare for physicians that were graduating. I said, what are you talking about? He said, well, if you look at all other professional degrees, they're equally diffused throughout our industrial ecosystem, except for physicians that are all focused on patient care, and yet that's such an important part of our economy. It would be nice to have that voice expressed elsewhere as well.
Right.
Yeah.
Do you think, you mentioned 20%, and that's a ballpark number, I'm sure you can take it out to several decimals. Healthcare, roughly 20% of U.S. GDP. That's a lot higher than a lot of the other countries of Europe, certainly. Is it too high?
It's probably too high. In fact, we probably spend $3 trillion on a $2 trillion problem. And
so it's 50% too high.
It's probably about a third too high. And when you look at that, there's a lot of administrative churn, administrative cost. Some of that is data has to be reproduced because it can't flow from place to place. Some of it is we take this physician workforce and we only effectively utilize a third of it. And the other 2/3, we say, why don't you be a data entry clerk?
Right. Which is where we began, right?
Which is where
the doctor spends an hour with a patient and 1 to 2 hours putting data into a computer.
And information flow. If I'm a patient at University of Chicago and I have a long, complicated medical history, and at 2 o'clock in the morning I'm in an accident and I show up at Northwestern, it's as though I never existed in any physician's office before.
Right.
There's not good data liquidity.
So do we need a set of national standards? Do we need to let the big data companies, Google, IBM, on and on, Amazon, I shudder to say, help us figure it out? I mean, what's the path forward that lets doctors be doctors and get back to tending for patients?
If you look at our work in Chicago and also in Silicon Valley, what you'll see is we engage all asset classes of the health system. So consumer technology, corporate technology, all of these different classes have to be engaged because it can't, our problem is being siloed, and we can't approach a solution in a siloed way.
Right. Yeah, that's certainly one of the themes. We could go on, and I'm sure everyone here would like to hear more of you. Dr. Madeira, thank you.
Thanks, Adam.
All right. Very thoughtful man. You can understand why he is the head of the AMA. And he went on to tell me, by the way, that for every hour doctors spend with patients, on average, they spend 2 hours crunching numbers and inputting data. That's not an efficient use of time. And it really brings us to our next guest. One of the reasons that doctors experience burnout is because they're not being able to use their time efficiently. They're not treating patients. That's why they're doctors. That's what they want to do. Christine Sinski is a doctor herself. She is also the president of Professional Satisfaction with the AMA.
Hello, I'm joined by Christine Sinski of the American Medical Association. Christine, thank you so much for joining me today.
My pleasure, Emma.
Thank you. Oh, you're welcome. So tell us a little bit about the session that you spoke at today.
Sure. Well, we talked today about the role of the EHR and about burnout and how those two are connected. And in fact, U.S. physicians are exhibiting an extreme amount of burnout right now. Over half of U.S. physicians are burned out. And part of that is related to EHRs. Not the EHRs alone, but how they've been used, how they've been implemented, and some of the non-clinical uses of the EHR.
So what leads to that burnout? Are you giving some examples?
Sure, happy to. I think for many physicians, we realize that we are spending our days doing the wrong work work for our patients, that we are spending our days doing clerical tasks that we know don't add value for the patient, but they are these mandatory tasks that have come down. And in fact, we did a study with researchers from Dartmouth. We looked at 57 docs from 4 states and 4 specialties. They used 7 different EHRs. On average, there was 2 hours of EHR and desk work for every 1 hour of direct FaceTime with patients. So we know that that's probably not the best use of physician time for patient value.
Absolutely. So how do we make those changes to make the best use of everybody's time?
Right. Well, so I think we need a number of things. There are some improvements in the design of EHRs that will make things better, but we also need improvements in the regulation. Sometimes the regulations are constraining physicians from team-based care and sharing some of the work. Sometimes it's the interpretation of the regulation. But the regulation isn't the problem, it's how the local organization has over-interpreted it. And then some is teamwork, that we become more comfortable sharing some of the work with our team members, particularly sharing some of the documentation work.
Sure, absolutely. So what does the next 5 years hold, or even this year for this area?
Sure. So I think one of the most important things we can do is move away from thinking of healthcare as a transaction, and think of it as a relationship, and that we then try to support relationships. So we make sure that our EHR is really supporting team-based care and supporting the doctor-patient relationship, the nurse-doctor relationship, the nurse-patient relationship. Make sure that all of those are supported by the EHR.
Absolutely. So are there any specific successes or any geographical areas that this is being, changed and streamlined at the moment?
Sure, there are lots of bright spots in the country where physicians and their teams have developed a new model of care where, in particular, medical assistants or nurses can make a more substantial contribution to care, and we do this in my own practice.
Okay.
So in my practice, the nurse stays with the patient from the beginning to the end of the hour. And during my component of the visit, they're also in there with me. So they are helping with data entry, data retrieval, they're helping with interaction with the patient while they're present. And it really makes a much more rich experience for the patient.
Absolutely. You would know firsthand, obviously, so that's amazing. Well, thank you so much for being with me, Christine, and I hope you enjoy the rest of your time here.
Thanks so much.
Thanks, everyone.
All right, welcome back. So while I have been sitting here at the desk, Emma Meyer has been working the floor.
I have been.
Out on the convention floor. Yeah, I mean, you have been busy, and you've talked to a lot of people.
I've talked to so many people. So I spent the past couple of days doing some roving reporting around the floor, just interviewing a lot of our attendees and how things are things for them.
So that HIMSS TV can actually get out there and talk to people, as they're excited about their products and their booths.
Absolutely, and a lot of them are, so you've probably seen a couple of these on here as well, but one of the things I'm really seeing and learning a lot about is something that's very near and dear to me, which is the ease of use of a lot of these incredible technologies, which is something that you would think a lot of these would be incredibly complicated, but they're not, and that's what I'm learning from people, so it's been really interesting.
Do you think this year is different? Like I don't know, and I say that in part because the Internet of Things is just accelerating so fast. I feel like there's more tangible stuff that we can actually touch as opposed to, talking about databases.
Yeah, and that's a really good point that you bring that up, and especially in the expo hall, some of the displays, I've seen the things that we can really get our hands on are incredible. We're not just talking about cloud anymore. And obviously this is huge what we're doing here, and the competition is extreme too, so it's really nice to see what types of things are kind of differentiating.
Well, has there been any tension at any point between, I mean, you've got competitors back to back, sometimes right next to each other. Do you ever sense that as you're out there, kind of working the room?
A little bit. I think people are really excited about what we're doing with HIMSS TV and want to be part of it. So I can kind of sense that competition, which is not a bad thing.
Yeah, they all want to be on TV.
Yeah, exactly. Everybody, so I have noticed that.
People, it's like a dog. When a dog sees a bird, it gets birdie. Well, people see lights and they get, kind of TV-y.
Right, absolutely. And I've spent a lot of time on the floor, but also putting this on too. So kind of on both perspectives.
Well, that's a whole other conversation. We've been live now for several days, but you were here several days even before that. What was it like setting everything up?
Well, it was pretty intense, but I'm really excited because of the global reach of HIMSS TV has been incredible. We've been looking at the metrics every day for this, and it's just out of control.
You know more than I do.
I know, I can't
you know the numbers.
share that with you, but just tons of impressions, and we're out here, we're broadcasting to all of the social sites, HIMS.tv obviously, so it's really nice to see where people are coming in. We have viewers from Peru, Egypt, everywhere.
No kidding.
Yeah,
oh gosh, that's great.
It's very successful.
When I first started talking to the team about this, I mean, the assumption was there are going to be 45, maybe 50,000 people who attend, but as many as that is, there's still more who want to be here and can't.
Yeah, exactly.
And this is the way that we can bring them
That's a
here.
perfect point. So I think by blending with especially a lot of the man on the street interviews that I've been doing, it does allow people to see those booths up close and personal and kind of get a feel and be able to say, hey, you know, that's Joe. I know him. I've seen him before,
totally.
and get a feel for it. So that is our goal, to really expand here from the news desk, because this place is huge, as you know.
Have you had a favorite moment yet so far?
I think that my most exciting moment was when we went live for the first time and had an amazing show.
And all the work that went into it, suddenly, you know, it's worth it.
It's definitely worth it. So it's been very exciting. I'm excited again to hit the streets and get a couple more interviews and see if I can cover any more ground here.
Fantastic. All right, well, we'll let you get back to it.
Perfect. Thanks, Adam.
Okay, thank you, Emma. All right, David Harlow and Nick Vanderheiden, otherwise known as Dr. Nick on social media. I had so much fun interviewing each of these two gentlemen the other day. I said, can you come together, because I think we have one on the pro side of security and one on the anti side of security. So we had some fun. Let's enjoy this. One of the reasons I enjoy coming to HIMSS is that I get a chance to meet so many different people. And if we're lucky, we actually get to bring them together simultaneously, and that's what we're actually doing exactly right now. David Harlow is principal of the Harlow Group, LLC. It's healthcare and law consulting, and of course we're joined as well by Nick Vanderheiden, whom you've already met. He kicked us off today as founder and CEO of Incremental Healthcare. Nick, Dr. Nick, thanks for coming back.
Thanks
David,
for having me.
you as well, since we actually spoke yesterday.
Yes.
And what I wanted to do was bring together two people whom I really enjoyed speaking with earlier and say, you know what, we're going to have some fun and talk about security, because my theory here is that we have someone who is in favor of, shall we say, maybe a little less security or a willingness to knock down silos. Dr. Nick, I'm thinking that's you. And David, wearing your lawyerly hat, that you might be more in favor of more security. Is that a fair?
Fair enough. I think that's absolutely right. The challenge for anybody that's sitting in a clinical setting where you're faced with hundreds of patients, lots of things to do, anything that prevents productivity is a hindrance, and security has a tendency to make it difficult to practice clinical medicine.
Because we erect walls. We say, no, this is my data, that's not your data, this is my patient, not yours, you don't have access.
Absolutely.
David?
Sure. Well, I work with care providers and tool makers and tool builders as well, many of whom are resistant to the notion of security. But as I like to say, you know, the law is the law, the rules are the rules, and there's certainly the ability to do what needs to be done within a framework of security. And I help people build that framework and stay out of trouble.
Yeah, right. What are the protocols from your point of view when you're trying to establish those guidelines?
Well, when I'm coming into a project, I need to understand what is the use of the data involved, who has access to the data, and what are they doing with it, who are they sharing it with, in what format is it coming in what format and through what channels is it going out. And we need to secure those channels in an appropriate way. And really the biggest risk factor in any healthcare security situation is the human factor, human factors. We are all a mess of risks, and we need to lock those down in appropriate ways.
In other words, we need structures that protect us from ourselves.
Absolutely.
I mean, it sounds reasonable, Nick.
Yeah, but what he's essentially talking about when he says human factors is, of course, the clinician. So that puts us in the frame as a fault if we make a mistake, which inevitably we do. I mean, I think the reality of human beings is we make mistakes. And the challenge I have with that sort of perspective, whilst I absolutely agree in, you know, the confidentiality of information and the desire to sort of secure it appropriately, is ultimately, what does the patient want? They want the best possible care. And if I don't have the information because I didn't know I needed it, so this concept of need to know and those issues, that creates a barrier that is a hindrance to the overall practical delivery of the best possible care for that patient. And that's a challenge for a clinician.
All right, so how do you honor certain confidentialities and yet make it accessible? I mean, where's the common ground?
So I think one of the things that I would say around this is that I wish we could go back 40, 50 years when, there was just this level of trust that, if I needed the information, I would access it.
Well, now you're taking me back to not Wall Street. You're taking me back to Main Street, right? Wall Street.
Oh my God,
no.
not Wall Street.
A lot of trust.
No, but I feel like I'm on the Andy Griffith show, right? Where, hi, Opie. Hey, go see the doc. What can we do for you, Opie?
I think we need to sort of parse this a little more finely.
Please.
There's a question of security and there's a question of privacy. I 100% agree with the proposition that a patient could say, I don't care about the privacy of my data. I want to make sure that my data goes from here to there securely, so that people can help me, but it has to be securely.
Right.
So I'm willing to sign away my privacy rights within an overall secure framework.
Yeah, and perhaps the common ground here is a level of trust that says, I as a physician am going to honor that and access information. Unfortunately, it just takes one bad actor, and we've seen plenty of them, who accesses inappropriately information for all sorts of reasons. And the sad thing is it impacts everybody. If we could find some middle ground that allowed the physicians who are doing the best possible thing that they can, and allow them that full access within the boundaries, and deal with the inappropriate access as a separate issue so that we don't lump everybody together, that would be, for me, a better sort of path forward.
Right. Yeah, I like actually divvying it up into privacy versus security, because they are different issues.
Right, they are. Now, one battalion of the security police from the federal government has issued a draft trust framework around health data security, and that's out for public comment right now. So it'll be very interesting to see where we go with this in sort of a post-meaningful use world, and trying to reach a new collective understanding of security and a trust framework for health data.
So as soon as you said that, immediately the hair went up on my back, thinking, wait a minute, this isn't the government's role, this should be private industry, and yet the government is the largest payer in the country, isn't it? What, about 60%? If you add up Medicare, Medicaid, government employees, in effect.
Possibly more?
Yeah, possibly more. Stay tuned. So government maybe should have the biggest voice, or be one of the arbiters as we try to navigate. What's the draft resolution look like now?
Well, so the challenge is to build a workable understanding and agreement with the enforcement abilities of the federal government behind it, but with input from industry, with input from patients, with input from providers, because everyone needs to be on the same page in this respect.
How willingness do you two, and Dr. Nick, jump in here first, how willing do you think players at all levels would be to separate the privacy versus security issue and treat them separately, related but separate?
I think there's an absolute willingness to do that. The challenge is, how do you do that effectively and in the day-to-day practice? I can't think about it in those terms. I think about it in pure, what is the best possible outcome for my patient and how do I achieve that? And I don't know that I think necessarily as rigorously as appropriately my colleague does here, who says, no, these are separate issues. And I understand that, but I don't know that it falls down all the way to the clinical work phase. So the challenge is the implementation. I don't disagree with the principle, and doing it in a way that doesn't erect barriers of time in particular, that allows me to follow the protocols and be aligned, but without hindering my capacity to deliver the most effective care quickly to my patients.
All right, is it possible, and I'm going way out of the box on this one, that blockchain might actually provide a framework for how we might do this? In other words, blockchain is totally out there in the public realm, all right? So you don't have the privacy concern. There is no privacy, but all the data is encrypted, so unless you are one of the two counterparties, you cannot see it, right? I mean,
Yeah, so
again, I'm out of left field here.
I'm a big fan when it comes to this of blockchain. I thought the seminal paper by Eric Topol and Leonard Kish that talked about the sort of essentially patient control of data using a blockchain principle. The challenge that I believe exists with blockchain is our capacity to understand how we would achieve that and do so in a timely and effective manner. So I think we're a little ways away, but I'm very hopeful that there's an opportunity there.
Yeah, it's moving at light speed. It's hard to understand.
No, I think the operative word in your question is might. You know,
yeah,
I mean,
right. All right, no, that's fair.
We might get there.
I said I was in left field.
That's okay. I think we might get there. I think it's early days for blockchain. I don't think we're ready to rely on blockchain. I think the smart contracts that are an integral part of the blockchain universe are open to interpretation, and if we have a transaction that is cemented into the blockchain, we can't have a smart contract that is open to interpretation, because the whole idea is that it's black or white.
Sure.
So I don't think we're there yet.
Do you think anyone else is talking about this here at HIMSS the way we are right now? It's why I actually brought the two of you together, sort of the pro and the con.
I think the most interesting conversations are the ones where we can have discourse that is civil, something that tends to be lacking in a lot of instances, sadly. I mean, truly. I love to disagree with people. In fact, one of the things that I love is an opportunity to take a counterpoint that I maybe don't believe in. It helps me understand it.
Yeah, right.
Sure. I wish we saw. So I think we do. I've seen it certainly in some of the tweet ups. As a social media ambassador, we were doing that yesterday. We'll be doing it today. I think more of that is absolutely part of that imperative with respect.
Yeah, right.
Right, absolutely. I think we need to bridge the gap between the tools that people are building around security and otherwise, and the implementation. And again, to me, it all comes back to the human factors.
And that's true, it is. It's all about the human beings, but if we could just accept that we're infallible and not apportion blame, like the airline industry did, the way that they reached Six Sigma in terms of lack of errors was instead of focusing on pilot error and what they'd failed to do, understand the reason for the error and fix the error, not the people.
Absolutely.
Yeah, I like it. Dr. Nick, thank you. And David, thank you, especially for coming back to let me put the two of you together, side by side.
Always a pleasure. Thank you.
Brian Eastwood is an analyst with Chillmark Research. He's also a HIMSS ambassador, and he's joining us here on the stage at HIMSS TV. Brian, thanks for being here.
Oh, thanks very much, Adam. Appreciate it.
So ambassadors like you help us get the word out. What's the word that you've been trying to push as you make your way around?
So I focus on patient and consumer engagement technology at Chillmark, and so I've been sitting in on sessions where that's a key topic. One recently was
Which could almost be like every session here.
It could be.
I mean, patient engagement is huge.
It is. It's a key. It's a key driver for a lot of what organizations are starting to do. As they make the transition toward providing more value-based care as opposed to volume-based care. They want to, better interact with patients, reach out to them, see what sort of services they need to help them avoid going to the ED or going into high-cost, like long-term post-acute care scenarios. Are there ways that they can take care of themselves at home or through lower-cost services?
And isn't it amazing that this whole thing now is about doctors reaching out to patients, having a regular dialogue? I mean, I remember I hadn't gone to the dentist for literally several years. I never got cavities, so I said, why do I need to go? And they said, no, you're missing the point. We want to just make sure the rest of you is okay, and your mouth is a gateway to your body. I mean, like, really?
Yeah. I mean, dentist offices are a good model for that type of engagement when you think about it, because they're the ones, they send you those reminders. I get text message reminders, go to the dentist.
And every 6 months, they're,
And they're able to, they can kind of build that rapport and build that dialogue. It hasn't quite filtered into primary care as much, and I think a lot of it is there's just so many different things. There's so many different conditions. There's so many different symptoms that you might present, and physicians' offices don't have a lot of time to spend with patients, so they don't always get to know what might be driving the decisions that they're making or the behaviors that they have, they're healthy or not.
That's an interesting point that you bring up. Data from the AMA suggesting that for every hour a doctor spends with a patient, he or she has to spend 2 hours doing all the back office stuff. And
Yeah.
so that, I mean, it kind of fights at that whole engagement thing in the first place.
Yeah,
doesn't it?
and that's why I think a lot of healthcare systems, a lot of healthcare insurers as well, and a lot of the vendors here are trying to improve the engagement, the outreach in between those care episodes, understanding that there's pressures on physicians to not be able to spend as much time with patients when they're in the office, but be able to say to them, okay, we have this service where you can correspond with us as you need to, or if it gets to a point, here's a program we have that will help you manage your high blood pressure, or something as simple as or physical therapy or other things where in between those shorter care episodes, the physician's office, the specialists know what a patient has been doing, and that makes that visit a little bit more fruitful.
Are you taking your meds? As simple as that.
Exactly.
Older
yes.
people may, forgetful, or they're stubborn.
Exactly. I mean, medication adherence is a great example.
Yeah.
It's a problem that has been identified as contributing to upwards of $300 billion in medical costs, because when people miss medications, their symptoms worsen, or and then they present in urgent care or in the emergency department. And if you are able to find a way to give them some sort of application or even a device to help them track the medications that they're taking and improve that adherence, they're more likely to stick to the care plan they're on and achieve the health goals.
Okay, so now let's make the jump and get specific. Are there health systems, are there companies, are there providers, et cetera, who have made this jump to integrated healthcare and who are really leading the way?
I mean, a lot of the leading systems are ones that have been at this for quite some time. They've had experience in providing value-based care by sort of serving as their own health plans. The clear examples are Kaiser Permanente and the Geisinger Health System. Other systems that are really working to improve their engagement model are the Partners Healthcare Group, particularly in looking at services such as telehealth, where they're really building up that as a model of providing more virtualized care, both within the care setting and outside of it once a patient has been discharged, to really ensure that they are able to stick to the care plan that they're given when they discharge after having been diagnosed.
Yeah, that really is the path forward, and I feel like this is a conversation we might not have had 10 years ago.
No, I think 10 years ago, a lot of those processes were still very analog. It was a lot of phone calls. It was a lot of sort of paper discharge summaries or paper care plans, and those are still in place in certain instances where there hasn't quite been that push to digitize, or there hasn't been a lot of incentive to try and digitize the process or streamline the process. But yes, progress has definitely been made.
Yeah, it certainly has. Final thoughts as we go into the last day or two of HIMSS. What's your message as a social ambassador?
My message is, as social media ambassador, is that the role that social media, and Twitter in particular, plays in attending a conference like this, and also covering a conference, there's an incredible value in monitoring that feed. You can see, if you're in a session, what people in 5 or 6 other sessions are doing. If you want to connect with a vendor, you can find them. If you want to connect with people, you can find them. I mean, I've made a lot of great connections over the years at conferences like HIMSS. Engaging with people on Twitter when they're sitting in sessions. We meet each other in real life later. We connect, and we continue to share the dialogue long after the conference and years later, and help influence each other's work.
That's probably why Mark Zuckerberg's a billionaire.
But probably. Wish I'd thought of that.
Yeah, exactly right. Brian, thank you.
Thanks very much.
Thanks for all your good work as an ambassador as well.
Appreciate it. Thank you. This was a great opportunity.
Yes, and for all of us. All right, I want to share with you a conversation that I had earlier with 2 women. I was so moved by it, I just think it's worth listening to again. It's about patients' rights. Amanda Green suffers from lupus. She's had it for 35 years. Just managing her own illness has been as much of a challenge as just trying to stay healthy, and Max Stroud has helped her talk about how to tell that story. Again, this is all about patient advocacy. We have a very special conversation happening right now on HIMSS TV. Amanda Green, a patient advocate, healthcare activist, and the owner, author, etc. of lupuslady.net. An amazing person. I'm excited for you to meet Amanda. And Max Stroud, you may remember her from yesterday. She and I had a chance to speak. She's senior staff at Galen Healthcare. And what a great opportunity to speak with both of you. And you're actually hosting a panel later today, and it's about bringing patients and doctors together in a very intimate sort of way. Amanda, why don't you kick it off and tell us a little bit about your story and how you decided to team up with Max?
Well, it all started at HIMSS. Last year at HIMSS, when Max presented with her sister, it was a patient story at HIMSS, which I, as a patient advocate, I felt was very important.
Right.
And I was like, I want to tell my story, and Max knows how to bring it out. So,
yes,
hi Max.
She does. She's good at that.
Hi Max, I'm Amanda, LA Lupus Lady. Also, LALupusLady.net. Didn't mean to correct you.
Oh, please. No, we want it right. Say it again so we get it.
LALupusLady.net.
Got it.
But basically, LA Lupus Lady on Twitter. I tweet too much. You can find me there 20.
Okay, I do too. Are you on Twitter, Max?
I am.
Good. Yep, that's where we come together. Okay, so you went to Max and said, I want to tell my story. I want to let this be an example to others.
Yeah, and the patient experience isn't told enough at HIMSS. It's all about patient engagement and patient experience, but they don't have that many.
Not that many patients.
They're doing better, but they're including patients this year, and I'm so happy that I can tell my story and share my journey, and Max has helped me figure out how to tell my story to make it relevant to the audience, because they don't want to hear my entire story, but
sure.
How healthcare has helped me and impacted my healthcare. It truly has.
Yeah, improve your living proof. You've been living with lupus for 35 years?
35 years. Oh, yeah.
And here you are.
And here I am at HIMSS, and I'm sharing my patient experience, and I'm just a representative. I'm one person,
right?
But many patients have similar experiences. And even in our session today, we include a lot of people, and the social community of patients is pretty big. So we went out to them, we reached out to them, they're included in our conversation. And you know, it's important that data work for us, that it doesn't just work for the providers and the insurance, that it works for the patient.
So Max, this is really your specialty, using the tools of social media and communication and getting the word out. How do you go about that in Amanda's case?
Well, I think that there's really some simple questions that you could ask any patient group, any focus group. If you were really looking at patients as consumers, you know, tell me about your healthcare story. What are your goals for your healthcare? Not just I want to get better or I want cancer treatment, but like, what are your life goals and how does healthcare fit into that? And then what are the tools that you use today? What are the technological tools you use today to access your healthcare? And then where does technology get in the way? And those simple questions can really, that's what we use to bring out Amanda's story, and it's something that's recreatable. It's kind of a qualitative way to look at, you know, what's happening in the healthcare system and where are we really missing the mark. We're throwing tools and apps at patients all the time, but where is it helpful and where is it just too much and turning people off?
Now, in fairness, is that because this is all kind of new, you know, using apps? I mean, the iPhone was only created 10 years ago. So that people are excited and they're just seeing what works, or are we not doing it in a thoughtful enough way?
I think it's a little bit of a combination, but I think part of it is not doing it in a thoughtful enough way, and that as healthcare organizations or insurance payers, we tend to think of things as what's happening within my healthcare system. And so we build the tools for the people within those four walls. And our patients don't exist like that.
Yeah, right.
Our patients see providers in multiple healthcare systems. Our patients go on vacation in HIMSS and might need to get some medical care. You know, patients really need something that travels with them through time and information that follows along with them, as opposed to like, well, this is my chart in Epic over at this hospital and this is my chart in Allscripts in this hospital, and I have these two different portals, but then I find social media really helpful for connecting with other patients and learning about my disease.
Yeah, that's
state.
way too much for someone to have to deal with. I mean, how do you deal with this, Amanda?
Well, I was going to say, come to my session, to the session later today.
Find out.
But well, I go from, and during the appointment with my providers,
right.
I'm the patient, and then I become the health records manager. So as the patient, you know, they might tell me, avoid stress, you've been feeling a little fatigued, get some, avoid stress, get some rest, relax. But as the health records manager, I have two different, my rheumatologist and internist don't practice at the same institution. So as soon as I leave those doors, I become a health records manager.
Even though you're the patient?
Even though I'm the patient.
And do you want to be the manager, or do you not want to be the manager?
Well, right now I am, and I'm going to do it until there is a single EMR.
Entity.
I mean, not like our soundbite, but my soundbite kind of that I've been saying is, I have one social security number. I have one driver's license. I can't have, it's 28.
One patient ID? Yeah, right.
Yeah,
makes sense.
Not just one patient ID, but one complete medical record that if I have lab work at one institution, why can't, when I go see my doctor at the other institution, have the results of that lab work 2 weeks later?
Okay, I'm glad you've just said this. I came out of Wall Street, all right? And on Wall Street, you have what's called a prime broker, so that even if you have an account at Morgan Stanley and JP Morgan and Goldman Sachs, the prime broker brings it all together and says, here's what you own and here's what you've done. And that's what you're talking about. Be my prime broker.
I'll be right? I am my prime broker.
Yeah, but you want someone else to do it so you can be the patient.
I'll
just
start
get better.
a prime brokerage. I need to find a way to cover patient expenses.
That's part of the thing too, right? Is that when you're sick or you're dealing with a new diagnosis, you have a whole life adjustment, right? So you need time as a patient to heal. You need time to recover. You need time to work with your family and attend to social relationships. You need time to, make healthy meals. So all the work that we ask patients to do, like you need to go to this other office in the hospital basement and get paper copies of your record to carry them somewhere else, or you need to get online and take a screenshot of this and email it to this other doctor. That's time that takes away from their healing and taking care of themselves.
Yes, you're absolutely right. Max, Amanda, thank you. It's eye-opening. Tell us when your session is going to be later today.
Yep, it's 1 o'clock.
1 o'clock.
Palazzo K.
Palazzo K.
It's a really big room. Bring all your friends. We want to see it packed.
It's not going to be your typical HIM session. We're going to basically talk about how Lady Gaga and Health IT come together for this patient's journey.
I love it. Oh, that's beautiful. It's one of the adventure sessions here at HIMSS, and thoughtful. And as you point out, one of the rare patient sessions, patient-driven sessions.
And storytelling, I think, is a really impactful way of shifting the paradigm of healthcare, and one story at a time.
Sure is. All right, Max, Amanda, thank you.
Thank you.
All right, thanks for sharing your time and your story. I describe attending HIMSS as something like trying to take a sip of water from a fire hose. There is so much water coming at you, you can't possibly get the sip. So I asked Tom Sullivan, the editor-in-chief of HIMSS Healthcare IT News, to come on to the set here with me at HIMSS TV and just sort of make sense of all that information. Try to pull a couple of sips away that we could try to make sense of. So here's Tom Sullivan with the major themes of HIMSS 2018. Tom Sullivan is editor-in-chief of Healthcare IT News, director of content development for HIMSS Media. He's part of the team. Tom, good to see you.
Good to see you too, Adam. Thanks for having me.
Oh, always. So you are really the one behind a lot of the content that gets sort of filtered from what happens here on the showroom floor and sent out to the rest of the world. What excites you about this year?
This year, I think the most exciting developments are around machine learning, artificial intelligence. There's a lot of hype. There's some hope. We're starting to see use cases and clinical trials and operations emerge that really work. But most of all, I think we're seeing a foundation of connectivity and interoperability coming into its own, and that will enable a new generation of data exchange, but also clean data, the right data, so that it can be run against analytics, or rather analytics can be run against it for machine learning purposes.
Yeah, right. Now, granted, this is a healthcare IT conference, so you would expect to find people focused on data. But I've been intrigued by how many conversations I've had with people who are doctors. They were practicing doctors and have left because they wanted to have a greater impact, and they felt that actually healthcare IT data was the way to do it.
Well, there are a lot of doctorpreneurs, as they're affectionately known, and really, who better to take that mantle in terms of knowing what to do with the data, because they have that deep understanding of medicine and the healthcare system, how everything works.
Yeah, right. HIMSS 2018, I think, or HIMSS 18, I think this is actually the 55th annual conference, and this year, as you point out, it's really one where machine learning it's real. It's no longer just sort of a gee whiz thing. Are there any kind of case studies, specific ones you can point to, companies that you've met that are really leading the charge and they have something that's actually ready for testing?
Well, there are the big ones, of course. I mean, Google's Eric Schmidt came and he talked about what they're doing, and he actually made a kind of a guarantee that if we invite him back for HIMSS 2028 or whatever it's called then, he would bring a tangible product,
But we have to wait 10 years?
Products. We don't have to wait 10 years for this to actually happen, but he did say he would have it, and it was a pretty forward-looking initiative. So.
By the way, pretty impressive and wonderful, and that's why so many people come to HIMSS, right? Eric Schmidt, CEO of Google, giving the keynote here at HIMSS.
It was great.
Yeah, phenomenal. Who else besides Google?
Well, Microsoft, IBM to a certain extent as well. So the big players, and then there are, there's no shortage of startups that are bringing exciting technologies. And I spoke with an EHR vendor. I don't want to name names here. You can read about it in the show daily, however, who's talking about releasing a new version in the fall that will include telemedicine. It will also include voice assistant technology. So that's moving in that direction. And I think this year what we're really seeing, again, is that foundation of connectivity, interoperability, clean data. That's setting the stage for where healthcare needs to go.
You mentioned Dr. James Madera, the CEO of the American Medical Association. I spoke with him yesterday, and he told me that on average, I was just shocked by this, that a doctor spends an hour a day with patients and 2 hours a day writing. I mean, it's actually probably more like 5 hours and 10 hours, but I mean 2 to 1, that is crazy. And I think what you're really getting at is trying to cut down that amount of EHR time.
It's certainly a big opportunity is to reduce the physician administrative burden by using new technologies.
Do we have a sense for well, and you probably don't want to name names, but I mean, who's doing it best? And if you can't name names, maybe just some.
It's not a case of not naming names. It's instead a case that I don't know that that's been determined. I mean, who's doing it best?
Oh, you're not taking.
Everybody would probably say that they're doing it best, but it's so early, and we're in such a foundational state right now that I don't know that anybody could credibly claim that they're doing it best.
That's interesting because I do feel like it's one of the friction points this year. Like I feel like there are a lot of people who are complaining that it could be better, but like I'm not seeing, the bright shining light that says here's the way forward.
Again, it's early. I mean, I think what we are seeing is that way forward, even if there's not one person saying or one company saying I have the answer. These are complicated problems.
Oh God,
very complicated, big problems that have taken a long time. It's not that they've taken a long time to solve. Excuse me. People have been trying to solve them for a long time. I mean, if you think about, so the surprise guest yesterday was Jared Kushner.
Yeah, right.
And it was kind of fun to be in the room when he came on stage, regardless of your politics, because now they're saying the Trump administration has a plan to fix interoperability. And talking to people throughout the show, some of them say, well, they're just rebranding what was already in progress under the Obama administration, or rebranding what was already in progress prior even to Obama.
And trying to claim it and own it.
Trying to claim it and own it. And, other people are saying, well, great, the federal government is now making this a priority.
They're doing something, yeah, right. Were you in the room when he came in? What was that like?
I think people were surprised.
But like happily so, or surprised like, what's he doing here?
Well, a little bit of both, maybe, depending on people's politics. I don't want to get too deep into that right now.
Because the beauty of HIMSS is it's not about politics. It's about patients.
Very well said. I think the overarching emotion in the room was, wow, we didn't know he was coming. Everybody was there to see Seema Verma. Probably everyone is aware that he and Seema work closely, and they've held some White House meetings on EHRs and interoperability.
Yeah, right.
So,
wow. Gosh, Tom, we could go on and on, but
yes, we could.
you know, I mean, there's just so much to talk about, and you really are the king of content here, determining what we all take away. So, thank you. That was Tom Sullivan, Director of Content for the media side of HIMSS. And now let's meet Sumit Sharma. He is Director of Social Media for HIMSS. Sumit, you're sort of Tom's online counterpart.
Yes,
His
exactly.
digital self.
Yes, it's my job to make him look good on social media.
Yes, well, you're doing an excellent job.
Thank you.
You've recruited all these people who are roving around as ambassadors for HIMSS and posting on social. A brilliant move, by the way. What inspired you to do that?
So the social media ambassador program actually predates me. It started about 5 years ago.
It's okay if you want to take the credit.
I can, but I shouldn't.
Right.
It started before me about 5 years ago. The idea was to kind of, healthcare IT, healthcare technology is such a niche world where we have all these people with such wealth, but social media is something that we wanted to use to bring the message to the, to the larger mass. And we found these great group of people who actually not just are social media savvy people, but they're SMEs in their own areas.
Oh yeah, they're passionate about.
Oh yeah, they're passionate about health IT, at the same time are passionate about social media. So it was a perfect combination.
Yeah, it really is.
Right, so we started it 5 years ago. My team that works with me right now, they started the program, and it just has evolved so much. Now we have 20 really great people who are social media ambassadors, and they are so passionate about it. So yeah, the program evolved over the last 5 years. But I think the mission here is, again, to bring the message to a larger group, right? And what better way to do it?
Well, and to make it compelling and exciting. I mean, if you were to just meet someone sitting next to a person on an airplane, the person said, "What do you do?" and you said, "Healthcare IT."
Right.
Right? And yet, these are people, and you're another one of them, in healthcare IT who are so excited to tell the stories about companies that are innovating health systems that are breaking the bounds, shattering the ceiling, the walls.
Right.
I mean, that's exciting stuff.
That
and
is.
Ultimately improving patients' lives.
Exactly. And it's not just patients, but professionals too, who are trying to understand, get educated about healthcare IT. They use social media for a lot of content consumption. Like Facebook used to be this consumer-faced network, but now it's becoming this place where people from all walks of life and professions are using it to consume content.
Now, okay, this is interesting because I find if I do businessy stuff on Facebook, I get no response. If I post a picture of skiing with friends or my cute dog or whatever, people love it. I don't know. Do you find that Facebook you actually get traction?
Yeah, absolutely.
Really?
So you might not get traction if you post about healthcare technology from your personal account.
Yeah, right.
But you might
Good
use
point.
when you're sitting on a train and you're scrolling through Facebook and an article comes about healthcare technology that matters to you and is relevant to you.
Right.
It's the easier way for you to kind of go in there and click on it and read through it.
Okay. Now I use LinkedIn for that.
Right.
And are you getting the traction on LinkedIn that you're getting on Facebook?
Honestly, Facebook actually. So all the networks do their own job, right?
Yeah,
So we do Twitter, Facebook, and LinkedIn. Those are our main three channels.
Sure.
They all kind of do their own job. So Twitter is the one where we get the most traction and most engagement.
Oh, interesting, yeah.
Right, like HIMSS 18 conference. In the first 2 days, we have 60,000 tweets that went out about the conference. In the last 20 weeks, it's been 165,000 tweets.
Wow.
About the conference.
Hashtag HIMSS 18.
Yeah, so I'm not even talking about someone just randomly saying HIMSS 18, but specifically hashtag HIMSS 18.
Yeah, right.
165,000 tweets.
Amazing.
So this is where a lot of buzz is happening. When it comes to content consumption, Facebook is top.
Facebook is top?
Top
Oh,
network.
interesting.
Yeah, Facebook is the top network. LinkedIn is strictly very, when the content is very technical, that's where LinkedIn performs really well.
Right.
Facebook is kind of top level, top of the funnel, one-on-one kind of stories, what's
Sure.
happening in the
Which makes sense.
Exactly.
I mean, that's Facebook. Where you're competing with fluffy puppies.
Exactly.
Right?
I like it.
I mean, you are.
Fluffy puppies. Yeah.
Those are the pictures in your feed.
Right. But they all kind of come together really well, and they all do something within the mix. So they're all really important to us, and we use them pretty actively all across the board.
Yeah, they all tell the story. Before I let you go, what do you think is the story for HIMSS 18?
What is the story?
Yeah, what's the story? If you could just, again, you've only got 114 characters now. I guess you have 247 or whatever they made it on Twitter. To you, what is the story of HIMSS 18?
Oh, I'll have to go back to our mission, kind of improving healthcare with the use of healthcare and technology, information and technology, and that's the story.
Yeah, right.
And that's the story we are trying to tell through social media as well.
Well, you're doing a great job, and
thank you.
Thank you.
I appreciate it.
We're all doing our part to get the word out.
Great being here. Thank you so much.
Yeah, thank you, Sumit.
Thank you.
All right, so someone else getting the word out, and what a story it is. Emma Cartmel, she is Managing Director of Capello Global. We spoke earlier, and again, this is one that I want to reshare with you. I think it's worth listening to. We have not met before, so we're just going to do this right on the fly. I'm Adam.
Hi, I'm Emma. Nice to meet you, Adam.
Hello, Emma.
Hi. Well, I'm spinning in my chair here.
Well, you know, it's we're perched up in a wonderful spot where we get to see a lot of what's happening here at HIMSS. What excites you about HIMSS 2018?
Well, there are so many education sessions going on. There's over 1,000 vendors on the HIM floor. I, as an investor and as someone who's an investment banker, I'm looking for companies that are looking to exit the market, wanting to sell themselves to larger enterprises, and I'm also looking for early stage investments. So I like to go
really both ends of the spectrum.
Both ends of the spectrum. So I really enjoy going through the HIMSS floor, and I like to go around Hall G, which is where a lot of the smaller companies are, a lot of the innovative companies, and I like to sort of trawl through and find some exciting innovations. So that's what I'm doing here.
Is there a sort of a theme to the startups that you're seeing down there on the G area, floor G?
Actually, a lot of them are consumer facing, and we've seen the industry really evolve. We've had a lot of EMR companies and then data analytics, and now we are seeing more companies come up, and how are we going to engage the consumer to change their behavior? And that is really exciting to me, because everything we've seen so far in digital health is a lot of it's been focused on what happens within the hospital.
Yes.
So I like now that we're trying to engage consumers to change their behavior and be accountable and responsible for their health.
Yeah, that's a huge theme. And I don't mean to sound so mercenary, but you are an investment banker. What sells right now?
So that's a great question. And I look at this from two ends of the market, so I've almost got to answer two questions separately.
Please.
So right now, formerly innovative companies were interoperability, telemedicine, clinical decision support, okay? And they were all the big innovations 10 years ago where I would have been putting angel money in. Now they're the mature companies that are getting ready to be acquired by some of the larger companies in the market.
Wow.
And so these earlier stage innovations are now mainstream. Most hospitals are doing telehealth. They're all figuring out their interoperability strategies, and a lot of them have implemented clinical decision support. So I feel as though they're beyond the innovation phase, and they're now in the growth and mainstream phase. Now, in the innovation phase,
and forgive me,
sure.
How many of those companies are public versus private?
Well, most of them are still private.
Yeah, they never went public.
That's right.
They're private, they're bigger, and then they get bought.
That's exactly right.
So for investors, it's hard to participate.
We are seeing, publicly traded investors, absolutely. Yeah. It's mainly the VCs who are going to cash in on this environment.
I'm a stock guy. I'm a publicly traded company guy, so I feel left out on this wonderful upswing.
So there are some publicly traded companies in this space, and they've been doing a lot of the acquiring. So I expect that you will have opportunity to participate with some of these earlier innovative companies that are now more mainstream in some of these publicly traded companies.
You want to name names?
No.
No. All right, fair enough. And then I interrupted you. You were about to talk to innovation. In other words, the new kids on the block.
Yeah, the new kids on the block. As I said, there's three areas. One of them is quantified self, so all the apps where we're collecting the data. One of them is patient engagement platform. How do we engage the consumer? How do we make the consumer accountable for their health? What platforms are out there to really get the consumer to engage and take care of their health? And there is a great company called BeWell on the floor I came across.
All right, should I write this one down?
Sure.
Public?
Not yet. Small, just
I'm writing
really
it down
getting out
anyway.
in the market.
Be well.
Be well. Letter B. Dot well.
Oh, letter B dot well.
Yeah.
All right, tell me about Be Well.
So I really like them because they are collecting all the data. So when you go to the doctor, you have your electronic medical records, you've got all your appointments, you've got your prescriptions. So as a consumer, I want access to my records. And if I'm going to see multiple doctors, I want one place where that's consolidated. I want my dental information in there, right? And also when I get a prescription, I want to be alerted that my prescription's ready to pick up, and I want to see coupons so I can see where I can pick up my where's the cheapest place to go and pick up my prescription. Now, ultimately, in an ideal world, I'd like my prescription to be delivered to me without ever having to think about any of that, but we're not quite there yet. We're getting there, right? So the other part is that if I need an appointment, if I'm missing an annual checkup, that app will remind me. If my kids are missing an immunization, I don't have kids, but if I had kids and they were missing an immunization, then this would remind me. But it also gives you timely content. So if I'm following a health and wellness program, if I'm trying to stop smoking, if I'm trying to drink less, this app will help guide and incentivize me toward those healthy behaviors. So what I love about Be Well is it really is thinking about all consumer engagement with the healthcare community.
So I had a conversation about a half hour ago with two ladies, and I said, oh, what you're talking about, and you'll get this being a Wall Street banker, I said, you're talking about creating a prime broker, a clearinghouse that brings it all together, right? If I have an account at Morgan Stanley, an account at Goldman Sachs, account at JP Morgan, there are 3 different places. I want it centralized into one location, and you're saying Be Well kind of does that for me?
Absolutely.
Love it. That, like, we should all be
it's really exciting.
Finding Be Well companies.
Exactly right. And I think they have the opportunity to be the unicorn in the market. Wow. And that really excites me. And I really hope the company grows up to go public so that you and I can buy stock in it.
Please. That would be outstanding. And we'll talk about it at HIMSS 2022.
Yes.
Emma Cartwell of the company is Capello Global?
That's correct. I'm an investment banker at Capello.
Well done. And thank you for joining us.
Thank you very much.
Really appreciate the perspective.
Thank you.
Part of the story here at HIMSS is breaking down walls, borders, going overseas and trying to provide health care in the best possible way. And that's why we invited Yuri Ueda to join us. She is Director of Health 2.0. And she came here onto HIMSS TV to talk about healthcare investment and finance in Japan. Well, what a surprise. Tell me all about you.
Okay. My name is Yuri.
Yes, Yuri.
And I'm a medical doctor as well as a director for Health 2.0 Japan. So basically, the half of the week I work as a clinician. My subspecialty is the plastic surgery, but I do the home care medicine. So mainly I manage the bed sore for elderly.
And what has brought you all the way from Japan to HIMSS?
Oh, to HIMSS because last year Health 2.0 was acquired by HIMSS, and now we are collaborating each other.
Love it.
Yes. So yeah, and then because HIMSS doesn't have the Japan division, we're kind of trying to see how we can collaborate in Japan or whole Asia.
Collaboration is certainly one of the themes this year, and maybe more willingness. I wonder if that's technology. And Japan is in so many ways so much more ahead of the U.S. in terms of sharing and people being connected with one another. Can you comment on that, the perspective of Japan versus America?
What do you mean by connected?
Well, connected in that everyone in Japan is digitally connected, and it's just part of the culture.
Yes.
And so many of the tech companies that pioneered all those technologies are Japanese. So I think there was just a greater willingness or an acceptance off the bat.
Yes. So by context of connected to the digital devices, yes, we are pretty much more connected because, well, most of the population, they have iPhones or the all electric devices. But in terms of the healthcare, that's totally different.
Yeah, well, that's true. And one of the things I've noticed as I talk with people is, and I pull it out, I've got the iPhone 10.
Yeah.
It's absurd how big it is, smaller than my old 6.
Okay.
But that somehow this thing could be a gateway to health, whether that's texting with doctors, whether it's collecting data, whether it's storing my data. I'm just fascinated by this thing, a telecommunications device, maybe being my gateway to health.
Yes.
I haven't quite wrapped my head around that yet.
Okay. Yes, most of Japanese people, especially for elderly people, that can be the gateway, but it haven't been the gateway yet.
Right.
Because, well, historically, the face-to-face communication is the base of the medical clinic practice, right? And it's still for now. And more, I should say, the digital devices are just helping tools, for sub-tools for medical communication. That makes sense. Yeah.
I love it. So as you walk the floor here at HIMSS on day 2, what are some of the booths that you want to go visit? Who are the people you want to talk to, and what do the conversations sound like?
Okay. I'm very much interested in the data integration. Because of the aging population burst in Japan, there is the governments are now leading to put patients into their home, back into their home from the acute hospital, chronic hospital, even the nursing home.
Yes.
But they want patients to stay at home.
Well, same in this country. I mean, that's one of the things we're seeing. And then there was a gentleman from Denmark who was just talking about building a new hospital that has 300 fewer beds for this very reason. They want to get people out of the hospital and back home.
So, but the problem is that the data just goes everywhere.
Say again, the which?
The data.
Yeah, the data goes everywhere.
Well, actually, the cloud-based EMR system has been imported 3 years ago, just 3 years ago in Japan. So it's quite new for us. The idea of the EMR is so, but now it's rapidly growing. The market is growing faster. But like I said before, the data is everywhere, and we have to integrate those because they want to stay at home. But if physicians don't know how they live at home, then we can't do anything.
Right.
So, and a nursing care home, like how they do the rehabilitation, how they treat patients for the cognitive reason and those kind of things, because the dementia is a big issue as well. So we have to integrate all of those: hospital, nursing home, and home, patient, family.
It's the same. It's the same in the U.S.
Yes.
At the end of the day, they're patients.
It's the big issue.
Yes, it is. Thank you. Thank you for being here.
Thank you.
Wonderful perspective. HIMSS Crossing the Borders and HIMSS TV doing a whole new thing. This is the first year we've ever done HIMSS TV. Our 55th conference. I don't know why we waited 54 years, but maybe the man who can answer that for us is the one I'm going to introduce you to now. He's the executive producer of HIMSS TV. In some ways, this has been your baby.
Oh my God, yes,
Getting
Adam.
the word out.
Oh my God, and I can't wait, because this is the best part.
Yeah.
Day 3,
yes,
of the conference, 3 days of broadcasting, to Roku's, to smart TVs, to social media, to HIMSS.tv.
Yes.
This is really exciting, but the most exciting for me right now, Adam, I'm going to turn the tables on you. I'm going to ask you a few questions. You spent 3 days asking dozens and dozens of people questions.
Interview the interviewer.
Yes.
Oh, wow, I like it. Now I get to be a guest.
The pupil's now the teacher type of thing.
I didn't prep for this, but I guess I don't have to.
I'm going to do like 4 questions for you.
Okay,
Question
all right,
1. What did you learn about HIMSS?
God.
Like, number one, couple of takeaways that you learned from this conference.
What a massive, massive undertaking it is to get companies, governments, educators, doctors, all on the same page, trying to do the best thing for patients. It seems so obvious. It's just not easy to accomplish.
And 46,000 people walking around all day long.
Who are passionate about it. I mean, everyone who came on HIMSS TV was excited to come on. People were, standing out there. We're looking out, you and I right now, and looking at hundreds of people. The convention hall is just on the other side of that wall. I mean, as you said, 45,000 people. I mean, it's mind-boggling. Everyone's so passionate about being here. I love it.
And what was the vibe, do you think, that HIMSS TV brought to the conference? Because you and I were talking off camera, and you were saying like you were pretty amazed by just the energy.
Yeah. It's sort of funny, if you take your dog for a walk and the dog sees a bird, the dog gets birdie. It gets all excited. And, you know, people walking around HIMSS are already excited. And then I think they see TV cameras and lights and they get more excited. They almost get birdie. And, you know, it creates a buzz. And I think that's part of the magic of it. For as many people as there are here at HIMSS, 45,000, there are arguably another 45,000, maybe even more than that, who couldn't attend. And I think HIMSS TV is about bringing what's happening here to all of them and making them a part of it. It's a huge community. We can't all be here at the same time.
One of the coolest facts that the audience should know, we had people from almost all over the world. I mean, you know, Latin America, EMEA, APAC, all over the U.S., Canada. I mean, we couldn't physically be here when we're watching this. And for the first time, being able to watch it on their 80-inch televisions, either in their living room or in their offices.
Perfect.
It's pretty exciting. All right, so you saw lots of innovation. Lots of people came up here. Come on, give me a couple things that you learned from the people. Like, what was your coolest innovation or technology that you saw?
Oh, gosh. The stuff that's happening on a cell phone. I mean, it blows my mind, and I don't know where my phone, here it is, that this thing is becoming the interface between me and my doctor, that this thing can store data that I can then share, that we're somehow figuring out, we're not quite there yet, but we're figuring out how to break down all the walls so that doctors can communicate with one another across health systems. But just the fact that I actually have the power as a patient and my cell phone might be the gateway, it just blows my mind.
Digital health is here to stay.
It's here to stay.
Patient engagement is here to stay. Yeah. Interoperability, security, and it's amazing, and it's all under one roof.
By the way, can I just be honest? I didn't really understand the word interoperability until I came here, and it was just hammered. Make stuff work together. That to me is what interoperability is.
And make it easy.
Yeah, make it easy.
And digestible.
Yeah,
which is really. We're so happy that you were here. You were able to pull a lot of amazing information out of every single guest we had, and hopefully you had a really good time.
Oh my God, I had a great time.
And from everyone at HIMSS TV and at the conference, thanks for making the 3 days of this broadcast a pleasure to watch.
Thank you. I'm here because of you.
Thank you.
Thank you.
Thanks
for having me. All right, Ben. So. Thank all of you for being part of this. HIMSS is a community. You know, Ben and I are talking about all the people here, the 45,000, and again, all of the people like you who we wish could be here. But I think we're going to see you again next year. If not here, at HIMSS 19, we're certainly going to see you at HIMSS Television. So exciting. We're a part of a community that is improving the lives of people around the world, and we're doing it in tangible ways. You actually can touch this stuff. You can feel it, and you can see it in people's eyes, and you know it when you talk to them. So from all of us here at HIMSS, thank you.